complications. Let's start with the diagnostic. Dr. Saraswati Ramesh always likes a little bit of history before he starts, so this has got stuck with me. So it was, as we all know, endoscopy itself started way back in 1805. But using the cystoscope, the first hysteroscopy was done. In fact, way back in 1869 only a hysteroscopic polypectomy was done with using the primitive cystoscope. But the newer hysteroscopes and all, whatever revolution happened in the hysteroscope were in the 80s, early 80s, and that's when the actual proper what we use right now has started. So this is a picture from an old publication way back in 1898 only. Somebody tried using this primitive cystoscope and tried performing the hysteroscope. At that time there was no concept of distending the uterus and all, so I'm sure they wouldn't have really got much of a good image. But what really changed, and most of the current hysteroscope is all due to Hamau, and he revolutionized the hysteroscopy. And whatever we are using telescope as of now, the 4 mm one was initially introduced by him, and we are all familiar with the indications of whenever we want to do hysteroscopy. The list goes like this. Now, the contraindication for actually performing a hysteroscopy, obviously any active pelvic infection. Pregnancy becomes a relative contraindication unless we are doing a fetoscopic procedure. And if there has been a recent uterine perforation, for whatever reason, we have to avoid, because there won't be distension of the uterus. And if there is an active bleeding, again it becomes a relative contraindication, because you will not be able to visualize anything, especially if you are using fluid like saline or ringolactate. The blood and saline will get mixed. So if there is active bleeding, you will need to have a good irrigation suction. So there are some times when inevitable situations we have done hysteroscopy in active bleeding, but that becomes a relative contraindication. Now, when it comes to a setup for hysteroscopy, most of the setup is going to be common between hysteroscope and the laparoscope. So what remains common is our light source, what remains common is our camera setup and the light cable. Now, obviously now with advancement in technology, almost all of us are using the xenon light source, so gives a very good clarity of image. The camera again remains a common thing. Now, what we need extra is the hysteroscope itself. Now, hysteroscope has two components, the telescope itself and the outer sheath. Because what makes unique in hysteroscopy is we need media to distend the uterine cavity, and hence we need a sheath to provide the media. Now, in hysteroscope itself, what we all are using and what you all are probably seeing most often will be the rigid hysteroscope. Contact hysteroscope, I'll go through the next few slides with contact, flexible and the microhysteroscopy, but what has remained common is the rigid hysteroscope, and this is what you need to know in detail. I just had done this for you can just go through.
Now, let's look into the hysteroscope itself. So now in the hysteroscopy, the equipments include a telescope and the sheaths, the outer sheaths, which can be a diagnostic sheath or an operative sheath. Let's start with the telescope. Now, the telescope itself has an eyepiece to which the camera head gets attached, and this is where the light cable, which comes from the light source, gets attached. In the lens system itself, we have thinner diameter scopes and we have the thicker diameters. Now, this is a 2.9 millimeter diameter scope, versus in my left hand what we have is a 4 millimeter diameter. Now, the advantage of a thinner scope is the easier entry. The thinner the scope, easier the entry will be. Now, other important aspect of the scope itself that each one of should be aware is the angle that it subtends. This one, for example, is a 30-degree scope. So, in a 30-degree scope, when you want to visualize the cornua, you just have to rotate the scope. So, 30-degree scopes are very useful for diagnostic hysteroscopies. Now, in the meanwhile, I also have here a 12-degree telescope. Now, 12-degree telescopes are particularly useful for operative hysteroscopy.
So, most of us in most hospital would have invested in a 4 millimeter telescope, because if you have to have one telescope, it will be a 4 millimeter, because it will fit into a resector scope and also for the diagnostic scopies. But if you have the luxury of having many scopes, then you can have one 2.9, because 2.9 mm, the entry is very easy, especially if someone's doing an office hysteroscopy and all, it becomes like without anesthesia, it's a good telescope to have. If you have a nulliparous for infertility, that's a good telescope to have. Now, we'll talk about the sheath. Now, that's the next aspect. There are different sheaths in hysteroscope itself.
So, let's look at the outer sheath. Let me start with the diagnostic sheath. this diagnostic sheet has a channel only for the inflow of the fluid. So the hysteroscope goes inside. You have to make sure all the zeros are aligned and then lock it. Now this is the channel for inflow for diagnostic sheet.
So as we all know, we need some media to distend the uterus. Uterus is a collapsed organ. So for this reason, we need a sheath, and usually there should be a 1 mm space between the telescope and the sheath. That's why the sheath diameter will be 1 millimeter more than your telescope itself. Now most of the diagnostic will only have place for the inlet of the fluid. There, if you're just performing a diagnostic and coming out, it's fine. But if there is an operative or any procedure when the bleeding starts, you need constant clearance. So this is just good enough to peep in and come out. So otherwise you need something that has both an inlet and the outlet. Now what's important is all of us should be aware of whether it's laparoscope or whether it's hysteroscope, we should be aware of what angle it subtends. So what's available for us in laparoscope is 0 and a 30 degree, and most gynecologists we need 30 degree telescope. Now for hysteroscopy there is a difference. If it's a 30 degree, of course for diagnostic a 30 degree is good. Now because, sorry, does light come on here? Anyway, I'll go like that. So most of the time we use is a 30 degree scope. So in a 30 degree scope, because the cornuas are placed in a corner, if you have a 0 degree scope, obviously you have to turn the telescope to see this cornua, but obviously we have restriction in the cervix because cervical canal is rigid and narrow and we may not be always able to see the cornua. That's how a 30 degree scope becomes important for diagnostic hysteroscopy. So everyone needs to have a 30 degree scope. Now what's important, because it's a 30 degree scope, we should be aware of how we enter the uterine cavity. Now as much as possible, what is recommended is you don't sound the uterus or you don't dilate the cervical canal before entering. You better to enter under vision. If you end up dilating and if you create a false passage, you will end up going in the false passage and you'll lose the true passage. And we have the luxury of actually using the pressure of water to distend the cervical canal and enter. Now you have to always remember that we are using a 30 degree telescope over here. So if you're not aware of this concept of a 30 degree and 0 degree, what will we try to do? We'll take the telescope to the external os and we'll just try to centralize the hole in the monitor and try to go in. But what happens when you're using a 30 degree scope and if you centralize the hole, the os, basically you're hitting the posterior wall because your 30 degree scope is in straight line with the os, internal os. So obviously you're visualizing it in the center on the monitor, but actually you're digging into the posterior cervical canal, and that's why you'll find the entry difficult. Most of them perform hysteroscopy because as obstetrician gynecologists we are used to dilating. So we'll push the hysteroscope also like a dilator and enter the cavity most of the time. But that's not the right way to do it. It's always good to get into the practice because it's easy for many times, but when you are stuck with a nulliparous or an infertility or especially a post-menopausal woman, when you're going to have a tough entry, it's always good to practice from the beginning to enter under vision. So take your hysteroscope to the external os, wait for the fluid to distend the cervical canal and then visualize the internal os. So obviously if you are using a 30 degree telescope, you're going to be seeing mostly the anterior wall, then only you'll be going straight. So you should be able to visualize more of the anterior wall when you're entering, then only you'll be entering straight into the uterine cavity. So I had my own mnemonic when I was doing fellowship. So when you're 30 degree, this is my own, it's not, you won't find it in the textbooks. So if you're using a 30 degree telescope and it's looking up, your light cable is on the 6 o'clock. If you're watching the 12 o'clock, your light cable is 6 o'clock. So my concept, even now I use that. So if your light cable is at 6 o'clock, your os should be at 6 o'clock. If the light cable is at 12 o'clock, your os should be at 12 o'clock. This is what I still follow even today. So then comes this concept of an anteverted and a retroverted uterus. It's good to do always a pelvic examination before we start the hysteroscope. So if it's an anteverted uterus, this concept what I told you will help you. Because obviously a 30 degree scope, you're looking anteriorly, and if you keep your os at 6 o'clock, you'll straight away enter. But in a retroverted uterus, you're not going to be, even when you keep your light cable down, you're looking up, so you're not going to be able to see the internal os itself. In such a situation, you'll have to bring your light cable to 12 o'clock, so you're looking posteriorly, and that time the os should be at 12 o'clock in the monitor. So that's why you need to know your scope before you enter. So this important, if you follow this principle, most of the time you will be able to negotiate the os without dilating. And to some extent nowadays cervical priming with misoprostol also helps. Of course, there are a lot of studies debating this, but to a large extent I think misoprostol, all of us kind of use it as priming, especially if you are doing it in a postmenopausal women or in a nulliparous, and sometimes even in a previous cesarean. See, the other concept is for operative hysteroscopy, of course not everyone will have the luxury of having multiple telescopes, but if you have a 30-degree telescope, what happens when you push the loop in the resector scope, because it's 30-degree, the loop goes out of your vision in the end. So in the beginning, when you do any procedure like a myomectomy, hysteroscopic myomectomy, in the beginning of the procedure you're a little blind, you'll have to just make a guesswork, my loop is there, and start bringing. But in a 12-degree you have the luxury of visualizing the loop throughout. This is a 12-degree telescope that I'm using. So I push the loop completely and I'm still able to visualize the loop throughout in my field. This 0 degree is not commonly available. What's available for a hysteroscope is a 12-degree. Okay. So the other thing, these are things I think are more theoretical, but because it's used in the UK even now, I'm going to just mention about the flexible hysteroscope. It's 4.8 millimeter diameter and it's like our upper GI endoscope concept. So you will have a kind of flexible in the front. So this is quite a bit of flexibility to the range of 120 to 160 degree. So it's easy to cannulate with that because it can turn around, and the middle part is the rigid part. So this is a rotatory tip and the rigid middle part, and this is useful because you can negotiate through any kind of uterus, even if it's acutely retroverted, anteverted and all, because the flexible part is in the anterior part. But as you can see, you can only use it for diagnostic scopies and you can use it for cannulation of the tube. But apparently the clarity of image is not as good as the rigid hysteroscopes, and I think it was again used, probably still used in countries like UK for office hysteroscopy. They do a lot of office hysteroscopy, but I think with nowadays we have thinner, better quality office hysteroscopy. It never became popular in our country because the whole setup is quite expensive, and you can just use it for a diagnostic scope as an office hysteroscope, and you can't do much in terms of therapeutic usage. So somehow it never was, I think this presentation is, I started talking about it like 25 years ago and it has remained the same. Nothing much has happened in the last 25 years. So this is more like a theoretical thing that this exists. The other thing that is again theoretical is people used what we call as the microhysteroscope, where they actually, it's a contact hysteroscope. You touch the telescope to the endometrium and you get the, like basically you're seeing the histopathology of the endometrium under the microscope. So there's a lot of magnification of almost into 16 into 150. But the problem I think becomes that we are not familiar with doing the pathology of the, as obstetrician and gynecologists, we are not comfortable looking at the cells under the microscope and telling us it's hyperplasia with malignancy, blah, blah and all. So cost is always on the higher side. And to begin with, I think none of us were really comfortable doing a histopathology. We are happy sending the biopsy and asking the pathologist to look into it. So this is another thing that is still in the theoretical thing. Initially, some papers came out with it, but currently nobody is practically using it. It's still in an probably just... Exactly. So obviously it was not practical. It's not at all practical. You have to go, the distension has to be removed and then you have to do the magnification and reinterpret those cells. So all that becomes a little challenging. So again, this became a theoretical. So practical purpose, what we have is only the rigid hysteroscopes at this point, which is practically used by most of us. Now, as we know, uterus is a collapsed organ and we need to distend the uterine cavity. Unless bladder, which is much more pliable, uterus is a little more rigid organ and you need some pressure to distend the uterine cavity. The minimum pressure that you require to open it up is 40 millimeters of mercury. And after 70 millimeters, it's whatever media you're using, it's going to go through the fallopian tube into the peritoneal cavity. So you need to keep a pressure of around 70 to 80. So how do we achieve this pressure? Basically, it also depends on the media. Again, I'm talking about gas media, even though it's not used very much in our country. It is still used quite a bit in the West, especially for office hysteroscopy. Now, they use carbon dioxide as the distension media. Here, it's very important, especially when you're giving gas to distend the uterus, you have to maintain a pressure of 80 to 100 millimeters of mercury, because if you give very high pressure, it can cause embolism, carbon dioxide embolism, especially if a vessel opens up. So as a result, you need to keep the flow rate at 60 to 80 ml per minute. So you need a separate hysteromat. You cannot use the laparoscope carbon dioxide distension machine to use it for hysteroscope, because in laparoscopy we are giving in liters per minute, and here we are looking at ml per minute, and you cannot afford to cause embolism. The advantage of carbon dioxide as a media is you get very good clarity of vision. Like, we have been using laparoscope and it gives very good clarity of vision, and also you don't have water and fluid spilling all over in your office space. So especially when since I told office hysteroscopy is quite popular in the West, they prefer using carbon dioxide as the media over there. But only thing is you need to have a separate this thing for that machine itself, setup itself. This is what we are commonly using. What we need to be aware of is two things: the normal saline ringer lactate and the glycine. So practically we are using only normal saline bar ringer lactate or the 1.5% glycine if you are doing operative hysteroscopy. Now if you realized, when we use carbon dioxide as the media, again you can only perform laser and you can perform diagnostic. You can't perform cautery because the whole smoke comes into, and you can't do any operative procedure with carbon dioxide. So that limits our use as far as the carbon dioxide is concerned. But the fluid can be used for operative hysteroscopy also. So when we get out to practice now, these are two media that we have to be aware of. When it comes to diagnostic hysteroscopy or any surgery which we perform with mechanical energy like a scissor or a grasper, which, believe me, 90% of hysteroscopic procedures can be done with scissors now, including a septal resection. I use cautery only for myomectomy. That's the only place I use cautery. Otherwise, everything else can be done with scissor. So saline becomes a good media because the safety margin is really large with the isotonic solution. So saline, patient can tolerate up to 2 liters of deficit, and compared to glycine. So I'll be talking about media complications later. For practical purpose, diagnostic hysteroscopy, or when you're using bipolar energy for operative hysteroscopy, which is probably going to be it's already in now. When I started, bipolar was still in the initial part, but now most of them, when you're buying new machines, they're buying bipolar. But the older people are still using who have invested in the monopolar are still using the monopolar. So when you're using a bipolar system of cautery, or when you're doing a diagnostic hysteroscopy, saline or ringer lactate is good enough. Only when you're doing a resectoscopic surgery with monopolar current, you need glycine. And traditionally, what's available in most OT is 1.5% glycine, because that is what the urologist uses for doing TCRE. And believe me, they have also started shifting to bipolar. Most of the urologists also are slowly moving to bipolar. It's only the older ones who are still in the monopolar. Nowadays, a lot more people are doing laser for TURP and all. So again, saline becomes the media over there. So at this point, I'm still talking about glycine because it's still available in the OT, and since most hospitals still have monopolar system, you need to be aware of the glycine also. Now, when it comes to how to provide the pressure to distend the uterine cavity, of course, if you have the luxury of having a hysteromat, because it's a separate equipment by itself, like our laparomat, you can set the pressure. So you set the pressure at say 100 millimeters of mercury, the fluid going in will stop. So you can control the entry amount of fluid that enters. So because what we are worried as a complication of media is if there is overload. So if you have the luxury of having a hysteromat, you can control that. But most hospitals will not invest, because unless your turnover is huge, unless you have a personal one, you invest yourself. You also, when you invest, you are looking at turnover, right? So most of the hospital will talk about return to investment, right? So very few people have hysteromat in their OT, unless you are yourself a big laparoscopy person, have your own hospital and can afford to use it. Otherwise, most of them end up using a simple pressure cuff. Now this is a modified BP pressure cuff. The only problem over here is, I know there is a gauge attached, but it will never reflect on the actual intrauterine pressure. So we just have to do it approximately, but with practice, okay, once the certain distension is reached, you kind of know, once your vision is good, you'll stop the pumping of the BP cuff. But otherwise, you need constantly, especially when you're doing an operative hysteroscopy, you need constantly a technician standing there. There's a moment, because as the bottle collapses, the pressure will come down. So you need someone constantly pumping the fluid, and this will never reflect on the actual intrauterine pressure. But I think most of us end up using this. That's what's available in our OT, and we end up using this because I think even the urologists use this pressure cuffs only. For them, no, the margin of error is much more, the bladder distance so much. So this is what's going to be available in most of the OTs. As in, you'll have to, this is not the regular BP cuff, you get these modified BP cuffs, but they're not expensive. So hardly like 2,000-3,000 rupees. So most of them end up using this. Now the other thing you can do is just hang your bottle 4 feet above the level of the patient. You don't even have to do any cuff, and it's supposed to give that 80 millimeters of mercury pressure. But when you're trying to enter, the practical aspect, when you're trying to enter the uterine cavity and that your os is quite rigid, most of the time you end up requiring little positive pressure. So you will need a modified BP cuff to give it, or many times, you know, you see a technician just squeezing the bottle and trying to push and all. But this is something you can afford it, and it's quite simple. Now the advantage of a low viscosity fluid like saline or ringer lactate, even if it spills into the peritoneal cavity, you know, it just gets absorbed. You don't have to worry about that. And the usually what is the problem is when you start operating and you're using saline or something as a media, once there's a bleeding, the saline and blood is going to get mixed up, and the vision will be like completely, you lose the vision in between. That becomes annoying. You know, you're shaving and suddenly you lose the vision. So you need a good lavage system. So you need to continuously have an outlet tap a little open. So there's continuous irrigation and lavage. So that is a disadvantage of having low viscosity fluid. So the other, whether glycine or saline, it's the same problem. They're easily miscible with blood. The high viscosity, again for theoretical purpose, you need to know. This was dextran that was used. It's very thick, and it had to be, you know, under positive pressure with a syringe pushed into the uterine cavity. Because it's high viscosity, it just stays. It doesn't flow out. So obviously it used to give very good clarity of vision also. But the problem here is it spoils the instrument. The dextran itself spoils the instrument, and you can have anaphylactic reaction because of that, and that becomes very difficult to handle sometimes. Though it's a rare complication, but it can cause anaphylactic reaction, and you need plasmapheresis to remove the dextran out of the blood system. So again, this becomes very theoretical, just for the sake of knowledge that you need to know that these are the different media, the gas, the low viscosity and the high viscosity. Now coming to the position, all of us are aware that we use a lithotomy position. Particularly, you need to take care if you're doing an operative hysteroscope or even a laparoscope, for example, when you have to make sure that all the pressure points are taken care of. Make sure, otherwise it can lead to nerve injuries. So you need to specifically take care the patient is comfortable at all the joints when we are performing the hysteroscope. Now what's important, especially if you are doing a operative hysteroscopy, that you need to have a monitor which checks the oxygen saturation, because if there is a complication, then we need ECG leads has to be there. So you cannot perform especially operative hysteroscopy without having a monitor. Then let's go directly to the anesthesia. Now technically we can perform hysteroscope, as we all are aware of. Now office hysteroscope is the next thing. So if you're doing a diagnostic hysteroscopy or even a simple small polyp and all, can be done as an office hysteroscopy, where they are just giving some NSAID before the procedure and giving local anesthesia. But most of the time, if you notice, the anesthetist will give a short GA, especially if they know it's a short procedure and all, they end up giving short GA, which is okay. But what is ideal for operative hysteroscopy is regional anesthesia like an epidural or a spinal. Most often spinal, because we are supposed to finish any operative hysteroscopy procedure within 1 hour. So spinal is like a preferred choice, because in case you have toxicity because of media, patient gets confusion, irritated, you can pick it up on a spinal, which you'll miss on a general anesthesia. So regional anesthesia is preferred for operative hysteroscopy. So when it comes to office hysteroscopy, as I've already mentioned, you give NSAID 1 hour before procedure, and we all are familiar with the paracervical blocks. So we go ahead and give the blocks. Now this is the instrument table that is for a diagnostic hysteroscopy, same as our DNC set, except that we have a telescope attached. Now let's coming to the OR position when you're doing the hysteroscope. I'm sure everybody would have talked to you about how the monitor has to be positioned in laparoscope. So bottom line is the surgeon, the organ of interest, and the monitor has to be in the straight line. So in a hysteroscope, obviously we are going to be standing between the leg of the patient. The uterus is in front of us, so the monitor should be front, or obviously anesthetist will be there to the slight to the left, like a lap collie where the monitor is placed. That's where our monitor is going to be placed. So whenever you're doing a laparoscope and then coming back to a hysteroscope, make sure you tell the technician to move or at least turn the monitor towards you, because sometimes mirroring can happen. So this concept remains for any endoscopy procedure, the surgeon, the organ of interest, and monitor in the straight line. Now, when do we do in terms of, again, like most of us, all gynec procedures are preferably done most post-menstrual. One, because obviously pregnancy is something that we need to rule out. Otherwise, the clarity of vision is best when you do post-menstrual, because if you do pre-menstrual, there will be a lot of haziness, endometrium is thickened, so you may not be able to always pick up a pathology. So, and bladder, it's good enough to empty the bladder just before they come inside the OT. Now, this concept is if you are using the regular speculum, tenaculum, straightening and all what we use with all our gynec procedure. So, what's important is you take the whole ensemble that you have done to the external os and start irrigating the fluid. So, it should have an hydrodissection. The fluid should open up the cervical canal, and you should not push the telescope like how we do with our dilator. Wait for some time, wait the cervical canal to distend and then go in. So, I have run through this already with you before. So, basically this is what you need to know, and this is how practically it will appear. So, when you are using a 30-degree scope, light cable at 6 o'clock, you will be seeing most of the anterior wall of the cervical canal, and this is where your internal os should be seeing, and with this you enter the cavity. So, initially serially go in, go and see the fundus of the uterus first, then see the ostia, then as you are coming out, visualize all the walls and come out. So, if you want to see the anterior wall, your light cable has to be in the 6 o'clock. If you see the posterior, you have to be at 12 o'clock or side. So, that is how you rotate. So, once you are in, you do not manipulate your telescope too much. As possible, try to manipulate with the light cable. So, I am sure madam will keep telling you this in the OT. Always hold the camera head in the left hand. You keep your right hand free to rotate the light cable, because in hysteroscopy, the rotation concept is very important. So, once you hit the fundus, turn the light cable to the right, see the right ostia of the patient. If you are not able to visualize, you can move it a bit, but you won't have much space in the cervical canal. So, you will have to learn to rotate the light cable. Now, once we have gone in, what are the images that we are going to see to interpret? One is a normal endometrium, one is a pathological endometrium. In the normal endometrium also, the endometrium will appear different in different stages of your menstrual cycle. So, in a reproductive, you are looking at two stages, proliferative and luteal phase, and in postmenopausal, the atrophic endometrium. And we should be able to pick up benign lesions, like this is what we are mostly looking at: myomas, polyps, endometritis, synechiae, foreign bodies, malformations and placental remnants. These are different images I am going to run through. Of course, pre-malignant and malignant lesions. Now, let us look into how the endometrium will appear during the proliferative phase. It will be just smooth, and you will be actually able to see the gland openings as white dots. So, this is how you differentiate from an atrophic endometrium. In an atrophic endometrium, it will be just smooth and you won't be able to see white dots. So, next time you are doing an endoscopy in a post-menstrual, just try to look at these gland openings. So, that is the proliferative normal appearance. In secretory, it will be much more thicker, the endometrium. It will, as you are entering only, it will lift up the endometrium, and the media is also quite cloudy. That is why we do not prefer to do hysteroscopy given a choice in the secretory phase. No. We just write normal endometrium covering cavity. Correct. So, if it's not a pathology, I usually write, if it's postmenopausal, I write atrophic endometrium, because you need to differentiate, especially if you're coming for postmenopausal bleed. But if you're doing for infertility, I just write it as normal endometrium covering cavity. If there's polypoidal, if it's polypoidal, hyperemic, that's how you need to diagnose. But this is only for our knowledge that, sometimes when you see thick endometrium, normal findings, different stages of the menstrual cycle. Because pathological thick endometrium appears different. They are much more, that we'll talk in, and much more hyperemic and polypoidal. This is just thick endometrium. And you will realize, especially after some time, when you still, whatever I say initially, to a lot of people will dilate and then go in with the hysteroscope in the beginning of your practice. After some time, you'll stop doing that. Your dilator would have lifted up the endometrium. You can actually see one endometrium photic. So, why this also happens is, moment I do for a lot of people. So, when I go in and if the endometrium is lifted up, they'll say, oh, it's a polyp, it's a polyp, it's a polyp. So, you need to know what's a polyp and what's a lifted up endometrium. So, they'll assume that is the, if you're not familiar with the images, you'll end up misdiagnosing. Atrophic will appear completely bland. You can't see any vascularity. You will not see the gland openings also. Now, this is just to give a comparison of different stages. Premenstrual will appear very congested compared to a secretory. Now I was just going through how to enter the cavity. This is vaginoscopy, where we have not even held the cervix with the valsalum. So this is very useful for office hysteroscopy. So you go inside the vagina, occlude the vulva with a hand or a mop. It gives a pretty decent distension. Then see the cervix under the vision. Under vision, if you notice, this is where the light cable is. This is the light cable wherever you see this arrow. So when the light cable is at 6 o'clock, keep the os at 6 o'clock, and this is entry without holding or without straightening the cervical or a uterine canal. So this is something that slowly get used to doing it in case we are looking at office hysteroscopy. So we also need to get a hang of these. So it's better to do when the patient under anesthesia, routinely after we get the hang of doing hysteroscopies, get into the habit of doing vaginoscope also. Maximum if you can't enter, you can always go back to your old technique, but just get into the habit of doing this. Now, the other, what I decided is, since most of the operative hysteroscopy is for benign lesions, I'll combine how it appears and the surgery for it together instead of running through it twice. So the operative hysteroscopy, what really takes time is actually assembling the resectoscope. So what happens is, nowadays, most of the operative hysteroscopies can be done with scissors. Very rarely you end up using resectoscope. So neither the nurse is familiar, sometimes you also get lost. So it's a good habit to in between, get it out and keep assembling, because assembly itself is a challenge in operative hysteroscopy. So other than the fact that we have a telescope, as I mentioned, given a choice, you should have a 12-degree telescope if you have the choice of telescope in operative hysteroscopy. But what is important is the outer sheaths. There's two outer sheaths there, one fixed into the other, because one is for irrigation, one is for lavage, one is for the instrument goes. You need to be familiar with the sheaths. And here it's very, very important that you have a constant irrigation and lavage, because when you're doing operative is when the field is going to get bloody. So you need a good system. So one is to keep the inlet under pressure and outlet with a little less, tap a little bit, or some people connect it to the suction machine at a very low pressure, so that you don't end up collapsing the uterus. But what you should be aware of before buying or before starting is what kind of electrosurgical loops you have, the types of loops, and also what system you have, whether you have a bipolar system or a monopolar system. I'll just run through. There are two different types of sheath. One is the Bertocci sheath, which is good enough for all your scissors and graspers, and the other one is the actual resectoscope sheath. I think I've just tried to describe this only. I'll play this only. Operative sheath. We have two operative sheaths over here from stores, the Bertocci type. Sorry, I tried increasing the volume. Operative sheath. We have two operative sheaths over here from stores, the Bertocci type. Now this operative sheath is meant for the 2.9mm telescope that we have. Again, I'm going to be aligning it with all the screws together and locking it. Now this operative sheath has a channel for inflow and a separate channel for outflow, and there is a channel to put 5 French instruments. So these 5 French instruments can be scissor or grasper, which go into this for operative hysteroscope. Now the other type of sheath that we have is for the 4mm telescope. It has two sheaths. One is an outer sheath and an inner sheath. Now the outer sheath has actually the channel for outflow, and the inner sheath has the channel for inflow, and also the channel for the 5 French instrument that can be used for operative hysteroscope. So what I showed in the beginning is the 2.9mm telescope Bertocci sheet. That was my personal one when I bought it like 10 years ago. So there is one channel for the 5 French instrument, a separate channel for inflow and separate channel for outflow. The newer one, which I made Cloud9 buy, which is supposed to be from stores. So whenever you all are investing, I want you all to check if there is another model. So what they have done, outflow is fine. For the inflow and the instrument, there's a common entry. So every time I put an instrument, my vision goes. And that's why I keep going back to my own personal telescope. So I don't know, that particular model which I have in Cloud9 is bad. So I mean, same thing with Apollo also. I made them similar time frame. I bought both of them. I need to relook with the stores guys and see if they've done anything else, especially when you're doing a tubal cannulation. Whenever you put the Novice catheter, because it's a common inflow for both the water and the Novice catheter, A nose catheter is a little bit thicker than your scissor and grasper. The fluid just goes off. You just lose the distension. I don't know why they have made it like that. So next time, I mean, if you guys are buying, I mean, I keep thinking I should ask the stores guys, but I keep forgetting that. But this is the problem we have with the newer stores B.E.S.T. So you make sure that there's a separate channel for the instrument and a separate channel for the inflow fluid. Otherwise, it collapses the system. Both of them are B.E.S.T. Both of them are stores only. Yeah, they're called B.E.S.T. Yeah, B.E.S.T. The first one was for a 2.9 mm. No, second one was for 4 mm. See, the first one was a 2.9. So I bought a 2.9 mm myself, and I bought that system because the whole thing becomes 4 mm. I use a 2.9 mm telescope, and with the B.E.S.T. it becomes a 4 mm system. So it's much narrower than the other one, and there's a separate channel inlet, outlet, and for the instrument. So there's no collapse of the gap. Yeah, it's like that. But the newer one is for a 4 mm telescope. That's what I said. If you can buy one, then you have to buy a 4 mm telescope because that's what's going to fit in your resectoscope also. So for that, the operative B.E.S.T. sheet that came with it, the inner sheath has the common entry for both the fluid and the instrument. It's like one, when you look at the other side, there's only one hole come. I don't know how the AV hospital one is. That's a little older, bought some time back. I don't think we had a problem here, but the new stores which I bought like 2 years, I made the hospital buy and I found this was a problem. So I thought next time anyone buys it, they have to keep an eye on that. So if there's a common, and you actually practically use it, this is the problem. When you sell it, you don't even realize that this has happened. Scissor is still okay, but novice catheter never negotiates. So I go back to my own person. That's why I've not sold my previous instruments because this is what happens when they come up. So this is the setup for operative hysteroscopy. That is the resectoscope. Now again, what I have shown is the bipolar resectoscope. It is 1 millimeter small, like 8 mm is the whole ensemble becomes, while a 9 mm in a monopolar system. Because the loops in a bipolar system are smaller than the monopolar system. Because in bipolar, you know, the current has to go from one loop to the other. So that's why they made it a little smaller. And these are the different electrodes that it's available. Both monopolar and bipolar, the electrode system is common. So what's commonly used is the loop. Loop is the one which is used for all the myoma resection, TCR, even a bigger polyp and all, you use a loop. Otherwise, the other instrument which we commonly use is the Collins knife. This is used for septal resection if you're using cautery for septal resection. So you basically need to be familiar with this. What you're going to be ending up using most often is the loop. Probably second more often is the Collins knife. Now the ball electrode is for spot coagulation. So more commonly used with TCRE when you want to just corno and all when you want to do the ablation. Otherwise, if there is a sudden hemorrhage coming out and you want to do spot coagulation, most of the time even we end up using loop only for that also, but theoretically this is what it's useful, and practically you will end up using mostly the loop. Okay. Now the TCRE itself is, because of I think Mirena and all, is not a very commonly performed procedure, but that if you are doing it, then ball electrode is useful. I'll just since I had made a video for this Hubli Society, so I decided to keep it.
So when it comes to operative hysteroscopy with resectoscope, we have two different arrangements over here, the outer sheath and the inner sheath with the telescope. Now when we look at the outer sheath, this is a 26 French outer sheath. The outermost sheath has holes for the efflux of the fluid. This has a channel for inlet of fluid and the outlet. So this inlet channel will actually go into the middle sheath. The middle sheath actually has a ceramic tip. Now inside this goes the obturator. Now this is one arrangement to keep it ready. So after dilating the cervix, this whole setup is inserted. Now meanwhile, in the inner sheath, so we basically have to put the telescope, keep this arrangement ready. So insert the telescope and the electrode is fixed. There are two holes for the electrode. Here I am demonstrating a bipolar electrode. See, the electrode can be loop, can be roller ball, can be Collins knife. The tip of the electrode is inserted into these, and the cable, the cable for the electrode is inserted over here. Now this whole setup is kept ready separately. Now once the outer sheath is inserted into the cervix, the obturator is removed and this whole ensemble is inserted.
So in resectoscope, you need to keep two different assembly. So initially, you will obviously use with an obturator. You will dilate it with up to 10 mm Hegars, and then in the bipolar system, it's 8 millimeter, and then you insert it like how you insert a dilator because it has an obturator. Once you remove the obturator, then the other side you should already keep it ready with the optics and the electrosurgical system over there. So what happens over here is there are two sheets. So the outer sheath has the hole, so there is continuous irrigation from the middle sheath, and there is a continuous efflux from your outer sheath, and the volume of fluid that goes is good. So the resectoscopes gives excellent distension compared to your diagnostic. The amount of fluid, the pressure that is maintained, and constant efflux is happening through these holes. So that is how it gives a good distension. So keep this whole thing ready and then only dilate the cervix. Especially the other system has to be kept ready, make sure it's functioning. Now, there are two systems, as I mentioned, the monopolar and the bipolar system. So in monopolar system, obviously we have to use glycine as the media. Otherwise, basically what happens when you use saline and monopolar, there is electrolysis effect and sodium chloride. There is no conduction of electricity. The circuit is not completed when you are using saline or lingual lactate. So you need to use non-conducting media like a glycine. So monopolar system needs glycine, and because the complication of glycine is high and can be quite serious, we need to make sure that we don't give unnecessarily very high pressure, because naturally when you're operating, you want to finish fast and you want a good vision. You keep telling the technician increase the pressure, but we need to be aware that as much as possible try not to go more than 100 millimeter, or try not to, obviously we don't always have a pressure gauge, at least try not to overdo it, like just enough for you to have a good visualization. And procedure nowadays you should finish by 1 hour, so I'll go through that later. Now, as I mentioned, there are two different electrodes, the bipolar system and the monopolar. Bipolar is marginally smaller than the monopolar. So the older generation who started off with a monopolar, they still find monopolar system much faster for them to operate compared to a bipolar, because the loops are smaller, so it takes a longer time. Slightly longer time, but then you also know the time you can take is also can be a little longer because you are using a safer media like a saline. So now the other what was mentioned is theoretically is cold loops. They are loops, but they are much more rigid. So you can obviously with the current electrode loop, if you try to dissect the myoma, it's going to break the loop. So there were cold loops available. Again, it's not available in the market. What's available is the monopolar and the bipolar system. Okay. Now, when you buy the resectoscope, you will have to choose whether you're buying the monopolar system or the bipolar system, because the resectoscope should fit into the system. And what we need extra over here, why bipolar is still people are waiting to accept, is the electrosurgical unit for bipolar should be providing you underwater cutting. So what happens, it's a little more, almost, I think it works at 1.5 to 2 lakhs more expensive than the regular cautery system. For a monopolar system, the regular cautery which we are using for any open surgery is also good enough. But when you are doing operative hysteroscopy with saline, you need an underwater cutting system. So if you are working in a hospital where the urologist is also using a bipolar system, it's useful. Again, same return on investment. So they will ask you twice to buy this equipment, because it's much more, definitely where is 1.5 lakh and where is 4-5 lakhs kind of a thing. The hospital will question you. So unless you have your own setup and can afford to buy, it's always good to work with the urologist to use the system. Other than this, let's go to the different pathologies that we see. I start with the polyp because it's one of the easiest one to diagnose and also to operate. So polyps, as we all know, are one of the common things we are going to end up diagnosing and operating, especially initially when you're doing hysteroscopy. This is one of the first and easiest ones to do. Now, polyp can present with infertility, can present with intermenstrual bleeding and postmenopausal bleeding. I find postmenopausal bleeding, whenever the woman comes with that and we find a thickened endometrium, 90% of the time it is a polyp. And if you do a blind DNC or a pipple, it is not going to pick up or treat. So especially for postmenopausal bleeding or asymptomatic thickened endometrium, that though almost always it's going to be an endometrial polyp. So we can avoid unnecessary hysterectomy, because if you have not done a polypectomy, they're going to keep coming back with either thickened endometrium or with bleeding, and you'll end up doing unnecessary hysterectomy. So this is a good habit to always post a postmenopausal bleeding for hysteroscopy, and it is very simple. You just need to take a scissor and cut the base. Now, how do you differentiate a myoma and a polyp? So this is straightforward, you know, it's a polyp. When it's a bigger polyp, so usually myomas are much more rigid and have surface vascularity. Usually polyps don't have a surface vascularity. And the other thing, polyp, they flap. Whenever you're distending the uterus with constant media, they usually have a flapping. Even if it is a bigger polyp, they tend to have a flapping movement, and because they have central vascularity, so surface appears smooth. Very rarely a very large polyp, you can confuse it for myoma, and that's when histopathology will probably sometime, we think it's a myoma and we start shaving because it's very large, and we think it's because polyp needs to be cut from the base, myoma needs to be shaved. So when you're shaving, you'll realize it's much more softer than a myoma. That's when you suddenly realize that it's probably a polyp. But otherwise, most often the polyp will have not very difficult to diagnose. Now, why we need to differentiate is, in a polyp, all you need to do is cut the base. However big the polyp is, you should not try to shave it. When you try to shave it with a loop, it's very soft. It doesn't really shave properly. So however big, take your time and try to identify the stalk of the polyp and just cut the base. That's what is required for a hysteroscopic polypectomy. And even if it's a large polyp, it's worth wasting time trying to identify where the base goes. Especially what's difficult is the fundal polyps, because you have to go above the polyp and reach the fundus, and your scissors are straight, it won't be angulated, so you will have to try a little bit of jazz to cut the scissors. But it's worth spending a little time and cutting the base. So cutting the base, scissor becomes easier than a electrode, because loop electrode, sometimes it's not always, loop electrodes are easier to shave. So either we can use, you can go, so basically you have a 30-degree scope, right? Or otherwise also you have a 12-degree scope. Don't use, obviously 0 doesn't, that's why even operative hysteroscopy, it's a 12-degree scope. If you want to, you have to manipulate the, like, above, below, both you can do. Either do half from below and half from above. Start from below, you would have cut something, go from side, cut a little, and then cut a little. So from all sides. Yeah, you will have to keep moving your cable. So go initially, you see whichever one is easier to approach, the posterior approach or the anterior approach. Go there, keep the cable down, you will be able to see up, cut that part. To as much as you can, you cut it. Then you come up again, cut the rest. It will get, suddenly you will see it's got dislodged. And so I don't know, did this video play? I was not focusing. Okay, now this is one of the most satisfying surgery to do. This is a very old video of mine. I think I should start putting the newer videos. But anyway, this is one of the most satisfying surgery to do, because the results are good. Whether it's for infertility, whether it's for intermenstrual bleed. So go to the base. This video is as old as my fellowship in AV hospital. This is an AV hospital video actually. So take time and cut the base. And because you're not using energy source, you know maximum, even if you perforate with a scissor, nothing really going to happen. And media is going to be saline. This is one of the easiest surgery to perform for operative hysteroscopy as a beginner. So just make sure you're as close to the uterus as possible. Now the advantage of using mechanical energy like a scissor is you're going to be, whenever you use electrosurgical equipment, you're going to destroy the endometrium a bit. So the current concept is, as much as possible, use cold scissor or cold equipments to do operative hysteroscopy. The only problem is when you reach the center, if there is a center pedicle and starts bleeding, you lose the vision, but it's not too bad. It's obviously, it will be a very small vessel in the middle of a polyp. So as much as possible, try to do a polypectomy with the scissor. Unless it's very challenging or something, then only go to the operative loop. It just goes. It will just stop. It'll this one small and little clot, and you can see the clot also when you do a hysteroscopy. No, anyway, once your polyp has come out and it starts rotating, you're going to use it won't come with your grasper, because the problem with these polyps, I'll tell you, we remove from the base, and her internal os will be narrow. It doesn't come out with a grasper when you pull, unless it's a very small polyp like the previous one I showed you. So you have to dilate and use either a small sponge holder or something to get the polyp out. So you get the polyp out, and then you do a rehysteroscopy, to see if you have left behind. You'll always notice there is one little clot sitting over there, that's all. You won't need to do anything for that. Polyps don't bleed much, because there's only one central vascularity and it will clot. By the time you remove your specimen, that would have stopped also.
And this
So you need to maintain that distance. So that is where the initial challenge will be. That's what I said. Even if you perforate with the scissor, you know nothing can happen to the patient. Nothing major. It's only that you will not finish the procedure.
So
but
I end up actually keeping very near to the scope.
Yeah.
And it just don't open up.
No, don't keep it too close also. You should be able to see the entire, that's where a 12-degree helps. In a 30-degree, it's a little more angulated. So 12-degree helps, but anyway, you'll get used to, can't always have 12-degree. That's where 12-degree helps, because you'll get the entire end-on view of your scissor. And you can be a little away and you can still see the scissor. In 30-degree, what happens, if your scissor is here and the scope is here only, just outside, so it will be showing you here. The tip cannot be seen. So when you come back too much also, you'll be stuck, because sometimes those polyps are, the angulation is tough. So you take your telescope, go under the polyp, lift the polyp with the telescope itself. Mechanically lift it and then put your scissor and cut it. So don't put the scissor first. Go with the telescope, go till the base, and then slowly bring your scissor out and withdraw your telescope enough to cut the base. So use your telescope, because we don't have the hysteroscopy luxury of having another port to pull up things. Yeah, so you will have to go with your telescope only and go. So same problem. What happens if you use a resectoscope is you get beautiful distension. I told you, 8 mm, and you get nice distension, and you loop 1 or 2 cautery and the whole thing, the polyp comes out very easily. But what happens many of the time when you're practically in the OT, arrangement of the resectoscope only will take some 15-20 minutes, telling the nurse, get it out, arranging. So you feel at that time, I'll just use a scissor and finish off the procedure only. So that's what many times happens. But if you use a resectoscope, it gives beautiful distension, because the amount of fluid going is also good. And just 1 or 2 at the base and the whole polyp comes out. And you have dilated the cervix also, because you have to put in an 8 mm, 9 mm resectoscope. The polyp also comes out, just flows out with your fluid. So that's another, if it's a straightforward and you want to get used to doing operative with a resectoscope, polyp is again a good surgery to start off with. You may not need it, but it's a good surgery to start off with. I think we finished this. Okay, then comes the myoma. So according to me, if you're doing an operative hysteroscopy, this is among the complexity, this is probably the most relatively complex surgery. So we all know that if you go typing of the myoma, type 0 is definitely a candidate for hysteroscopic myomectomy, and type 1 also is a candidate for hysteroscopic myomectomy. But type 2 is preferably avoided as much as possible, unless someone's really an expertise, then they do the type 2 myomas also. Otherwise, type 0 and type 1 should be approached. So as I mentioned earlier, this is a video, no. What will show up on the fibroid is the surface vascularity. That's how you differentiate polyp and a myoma, and it's much more rigid. It's just won't budge. It's just stuck over there. So now I'll just play both I'll start with this video. I think I'll do the myomectomy with this video itself. So here loop is the instrument that we are going to be using. So always identify the base and the top and start shaving from one side. So this I don't know whether this is a 12-degree telescope. It looks like a 12-degree telescope only. Anyway, shave it completely. What you need to do is bring the loop completely into the resectoscope, so that it is completely detached. Otherwise, you will end up leaving, if you don't completely bring it in, this part is still attached and it will keep flapping and your vision is lost. Start at one end, you've shaved one, and then go to the left and right, center, left and right. It's actually ideally to be started at the apex of the fibroid, whichever is the apex. Start over there and left and right, center, left and right, so that you can serially keep shaving till you reach the base of the myoma. So what's important is you bring in the loop completely inside your resectoscope, so that it's complete. And in between, you will, if there are too many things, especially if you're doing a posterior myoma, these pieces will keep coming back into your vision. So in between, you will have to come out and take out these pieces and go in again to get a better clarity of vision. So you'll have to keep shaving this till you reach the myometrium. You will be able to make out the difference. This is like how you can see these are white fibers. Once you reach the myometrium, you will notice it's a pinkish fiber. So you'll have to slowly shave till you reach the base. Correct. So this is where what is important in a operative hysteroscopy. So we always go to the fundus and shave backwards. And this is how our resectoscope is designed. Unless a TCRA for the urologist, they go front to back. The only surgery we do front to back is septal resection. all the other surgeries as much as possible you do from fundus towards you, because as I told you, if it's a 30-degree, you will not see the tip, and if you end up perforating the uterus with the active electrode, there is always a risk of injuring the bowel or the bladder, or you don't know what's beyond you. So always go beyond to the fundus, the cranial, and shave back. This is, even our resectoscopes are designed like that. The passive thing is coming back, the active is pushing, otherwise it passively comes back. That's the difference between a cystoscopy and hysteroscopy. They go front to back, we come back to front. So this is something that you need to be careful. Now, this is one is that's a monopolar, is a bipolar. That's a monopolar, and this is a bipolar. So bipolar causes, this is thinner, narrow diameter, so it takes a little longer. The pieces are smaller compared to a monopolar. Bertuzzi is only cold. No, they have a needle, bipolar needle actually they have, but it's not very practical, and it gets spoiled, and then replacement, I didn't get a replacement. Initially I had one needle which came with the whole thing. I tried using it for these polyps base, no, just burn, very small polyp, it's fine, but it's not, it was not very comfortable using that. I didn't perform the weight, and then when I asked for a replacement, I never got it. So otherwise it comes with a bipolar needle. I think even monopolar, I'm not very sure, but it came with a bipolar needle. Okay, so earlier we had Versa point, no. The Versa point also has those tips, bipolar tips it has. The same principle stores sell with their Bertuzzi. But I think what you can do with a needle is a septal resection. With the needle you can just go swipe left, right, left, right, left, right. But you can't do a myomectomy, you know. Small polyp base you can just core it like that. But anything beyond that, not possible with the needle. So as I mentioned, basically this is the important thing, backward or return movement of the loop is what is important, and every now and then you'll have to empty the cavity. Now the other new thing that has come, which I'm also waiting to see how it evolves, makes a lot of practical sense, the morcellation, it's a mechanical morcellator. The whole system itself is very expensive. They're looking at like, last I knew it was around 25 lakhs. So it's a very nice instrument otherwise, you know, it is, I don't know whether I have the video here because some videos went off, but if you Google, it is there. And a lot of people, and in between they market, I've seen Dr. Vidya but also demonstrating it in conference. It's a rotatory thing, so it goes through your side port only, and it's a very thin, and it keeps rotating and shaving your myomas, and it also keeps sucking the particles. Takes a little longer, but it's mechanical shaving, and constantly, because it's sucking the particles, you don't have the particles floating also. So that is definitely a newer, it's there obviously since 2005 onwards, it's there, but I practically didn't pick up only because of the cost. In India now the company has come back again and trying to push that. In the conferences all I've seen, he's trying to push it, and he wants to keep it in and demonstrate and all, but the costing has to come down. The kind of costing, not everybody can afford to buy a 25 lakh only for a hysteroscopy setup, right? So that's where we are as far as the morcellator is concerned. Now the only mechanical, no cautery, no cautery. Yes, so advantage is saline and no cautery, and it keeps sucking the particles, the pieces, you know, it is a rotatory system over there. It keeps on the chop, it keeps chopping it like this, like a chopper, and as it's chopping, it sucks the tissue, very tiny tissues, but over a period of time, it just eats up the whole fibroid. So that again will take time for a large fibroid, but for a small fibroid, for polyp, for everything, it's very useful because it's mechanical. But the costing is so much more, so we need to, either they'll come down with the costing, or we'll have to wait and see. It's useful for everything, but very large fibroid, no, it will take so much time. That's what I said, people who are used to resectoscope, it will finish in half an hour, the whole big fibroid. In this, it will take forever to keep doing it. It probably is very useful in office hysteroscopy. So where you have a small myoma or a small polyp or something, and you just, like, you know, the postmenopausal with a small polyp and all, mechanically you can finish in the office hysteroscopy. They're trying to promote it also as office hysteroscopy equipment, but cost is going to be the challenge. Then what is important is how do we tackle the type 1 and type 2 myomas. See, type 02 you'll reach the base. For type 1 and type 2 especially is going to be a challenge to do the intramural part. So how much to dig in and take it. So what is important whenever you take up a patient for operative hysteroscopy for myoma, fibroid mapping is extremely important. So either you get a good 3D ultrasound. If it's one myoma, it's easy. If you have especially multiple myomas, get a good 3D image. Or of course, MRI becomes too expensive for everybody. A good 3D image so that you know exactly where the fibroid, and what's important in a type 2 myoma is the distance between your fibroid and the serosa. Because in operative hysteroscopy, I always keep telling people that you can't suture. So this distance is very important. The distance between the fibroid and the serosa, it's very close. There's a very high risk of perforation over here. So you need to be aware of this, whether this can be tackled better laparoscopically or whether it can be tackled better hysteroscopically. So always get a good 3D ultrasound. And I find sometimes useful if you are used to doing a transvaginal scan ourselves. It's always better to go in ourselves with a TVS and figure out where the myoma is. We have a better idea than reading somebody else's images. So type 2 myoma, if somebody is trying, they need to have definitely a clear image of what they are doing. And so how do we go ahead with the intramural component? So all of us are aware that the intracavitary part though will finish. The problem comes when you have reached the level and then how to proceed with the intramural. So there are different things you can do on the OT table. One is if the intramural component is not much, you're 80% is in the cavity and only 20%, you kind of dig with your loop itself. To some extent, without cautery also you can dig. Mechanically you can enucleate a fibroid. So mechanically with you gently push, you're safe, you're not into the myometrium, and shave a bit. Then push a bit, shave a bit. So there will be a margin, clear-cut margin between your myometrium and the fibroid. So some extent you can use a little mechanical force, figure out and keep shaving the intramural part of it. The loop with the loop, little bit you can dig in. If imagine it towards me, the fibroid and the myometrium, I can take the loop, little bit push, make sure it's the fibroid tissue. You can make out the fibroid tissue from a softer pinkish myometrial tissue. So it's a fibroid, you shave it a little more, then dig a little more and shave a little more. Like that you can continue the intramural part also with the cautery itself. Then the only problem is if you're not able to properly differentiate, or there's too much of, sometimes if you've shaved in pieces and there are too many things popping out, you don't know which part, you may end up damaging the endometrium, especially if you are using cautery. See, so in such a situation, what you can do is, one, you can come out, and 2-3 times you can go in and come out, what we call as distending and collapsing the cavity. When you do that, the myometrial portion comes inside the endometrial cavity. This is something that you can do on table. Second thing, you can give either a misoprostol or a methergin or something which squeezes your myometrium, so pushes this fibroid inside the cavity. So basically you're trying to bring the intramural part into the cavity. So if you're able to do either with mechanical in and out or with any pharmacological agent, like basically I think we all end up using misoprostol only quite often, and push it into the cavity. Yeah, it takes time, but if you're going to want to do it, you'll have to wait if you're doing it in a second sitting. Or you can give pre-op also. You can do pre-op also. Some people have done bimanual massage also. These are techniques that have been described, but they are not obviously very standard techniques. So obviously they're not very standard. We don't have large data on these things. So one is called hydromassage, going in and out. Second is bimanual. Third is pharmacological. These are things that people have tried. Otherwise, it is okay to do it in 2 settings. That also has been found useful, especially if it's a much more intramural part, like more than 50% is intramural and you're not able to abandon the procedure, take the patient after 2 months. In the meanwhile, you can even give a GnRH analog. That also supposedly helps. Or if you do nothing also, it is fine. When you go back after 2 months, it nicely comes inside the cavity. You'll be able to properly, there are like 2 or 3 times when I've done as a second sitting, and the whole thing is in the cavity. It comes out beautifully into the cavity and you can shave it off. So that is safer than trying to damage the uterus. So whenever we counsel a patient for hysteroscopic myomectomy, especially if you are dealing with type 2, or this particular one I was telling, we had 4 submucous myomas, 2 to 3 centimeters, shaved off 3, but I was almost more than quite a bit of fluid. I had only 6 liters of deficit she had reached. I was using bipolar, so saline, it was okay. I still stopped the procedure at that point. And the 4th one I had removed like probably 20, 30 or 40% of it. I went back after 2 months, it had come nicely inside the cavity. So that's something. Yeah. So pre-op, especially when you know this is going to be complex like this, better to counsel than you may end up needing a second sitting. I routinely do, even if it's a single fibroid, I feel there's an intramural component, just to be on the safer side. Counsel them and keep you finished good only, they'll also feel happy. But if you have not done, already you have counseled them for a second sitting. But second sitting actually makes life very easy. It really comes nicely inside the cavity. Except that we feel bad about, another OT charge, anesthesia, all that we also end up thinking the economical aspect of it. But from purely surgical point of view, intramural part comes out nicely into the submucous cavity.
When you stop in between, it won't continuously bleed.
No, it doesn't bleed. It doesn't bleed. That's why I think some people give GnRH analog also in between. While waiting for those period, give GnRH analog so that they go into anyway amenorrhea, so they don't bleed.
It is done on the GM also.
I know operative is under regional. I'll talk about it in complication. It's always preferably to, especially if you're using glycine, but otherwise also routinely all operative procedures to be done under spinal anesthesia. Why I'll talk about it in complication in detail. So the other surgery is only done hysteroscopically and relatively satisfying is the synecectomy. And again here there is no role of electrical energy because already the endometrium is damaged. So as much as possible use scissor for division of the so with a simple synecale like this, it's very easy. You just have to take a scissor and cut it. Here I realize the rest of the endometrium is nice and vascular. That's why the field became, initially it was looking like a nice synecale. By the time you put in your scissor and got it became bloody. But that's a straightforward synecale. The problem happens in there is Asherman's. You don't even know where the uterus is. So in this patient, it was an Asherman. You don't even know where your internal os is there. So here, instead of dilating blindly, obviously it will create a false passage. Under vision, if you see something, you can follow the cervical pattern of the cervical mucosa and then try to figure out where the os is and use a scissor to open up the os rather than blindly entering with a sound, because invariably in an Asherman you will end up creating a false passage. So especially in a patient when you are expecting dense synecale, always enter with vision. The other thing that helps in a very bad Asherman is I kind of use ultrasound guidance. My colleague shows me through ultrasound when there's really a cavity, we don't even know where what is in the endometrium, you don't even know whether in the myometrium or in the uterine cavity. It helps to use a transabdominal ultrasound to guide you. So you know you're in the center of the cavity all through the procedure. So it has to be only by mechanical. I think this one was one of those bad. She actually conceived after this procedure. So very, once the endometrium is destroyed, its little success of any treatment is on the lower side only. So we counsel them for that also. But some of them you don't know what miracle happens in some people's life. So this one, I only did the section for her after. I mean, this was obviously an IVF pregnancy. Did the section, endometrium looked quite okay. Now she's come spontaneously with second pregnancy. So it was a very bad endometrium. This lady had PPH. She had an IUD and PPH, and they had done B.E.S.T in some hospital. And then after that, she had, I don't know, I think secondary hemorrhage or whatever. DNC also was done. I can't remember what was done. I don't know why the endometrium was so badly damaged. I think B.E.S.T doesn't always do this. So it must have been along with it, they must have done curate. I have no idea, but it was a very badly damaged uterine cavity. So this we used ultrasound guided in, and then we made sure that we are in the center of the cavity all through. So this is one sitting. We had to do another sitting for the same lady because the endometrium, this much cavity we created, but the endometrium was thin. When my fertility specialist wanted to do IVF, it was very thin. So we did a second sitting on this lady. I don't have the video of that, and a little bit synecale was, but cavity looked much better than this. Then after second sitting, the IVF worked for her. So there, when you are totally lost in the cavity, you can use ultrasound guided. In spite of that, there's a case where I just completely got lost. Just couldn't figure out where the cavity. Finally, I had to abandon the procedure and told her like, just live with it kind of a thing. I thought I was doing under ultrasound guidance. I don't know where I went. When a laparoscope, the whole, obviously I was in some myometrial cavity. Whole pelvis was edematous because the fluid had obviously, but luckily I used bipolar or mechanical saline. So completely the pelvis was edematous. I just abandoned the procedure after that. But these are times we can totally get lost in a very bad Asherman's. I put a scope. No, this I didn't. that patient because we just couldn't figure out where we were, and under ultrasound also I thought I'd put a, and suddenly I felt I don't know, in the myometrium, or I had perforated, or I'd gone into a lateral pelvic wall. I just couldn't figure out where I was. So I put a scope for her. We always take a consent whenever we're doing a bad Asherman or a very intramural part of the myoma. I always take a consent for laparoscopy also. If I need, I will do it. No, if it's a polyp and postman, not routinely. For polyps or retained product and all, we don't take. If it's a proper intramural part is quite significant, or Asherman. These are two instances where I also take a consent for laparoscope concomitant. You never know in life when you have surprises. So I've taken a consent for laparoscopy, and when I went in, the pelvis was completely edematous. You know how the fluid is in the subperitoneal region and all, lateral pelvic wall, everything was edematous. She recovered very nicely post-op, nothing happened to her, but we just abandoned and we told her just give up on your fertility kind of a thing, or she went somewhere, I don't know, but I didn't want to put my hand again into her. So then the other very satisfying procedure is for uterine anomaly, particularly septum. Septum is the only thing, though nowadays they are doing metroplasty for bicarbonate and all, but as far as the literature is concerned, the only proven effective procedure is for septate uterus. So joining the bicarbonate and all should not be the first thing to be offered. That's only if everything has failed and no choice, then only you do the metroplasty. But as of now, the evidence is only there for septal resection. So what is useful before proceeding with the septal resection is a good 3D ultrasound or an MRI. So what you need to know is, because there's a lot of confusion when there's a diagnosis of this. Nowadays we are seeing what I call as partial bicarbonate. There's a little depression only, but the main part is the septum. That variation we are getting to see nowadays. Otherwise, classically we are describing whenever the indentation is more than 1 centimeter, it is bicarbonate, and otherwise flat is septate. This is a classical teaching. We're just seeing just about 1 centimeter indentation, and otherwise when you go in, it looks like a septate uterus, and we are resecting it, we are getting good results. What I call is partial. No, this is little bit there. So, but overall the cavity is good. So that is why you need to do a good 3D ultrasound. It's good if you have a radiologist in your own place. We taught our radiologist, we gave her the article and told her this is what we want. My fertility specialist is very particular. So we taught her, we gave her the article. I said, you start measuring this intercorneal distance, fundal distance, if this is more, you give her. So she makes a good 3D, and she could take a good 3D, but she didn't know how to interpret it. So it's good you take out the article and give it to them. MRI, or I find a 3D ultrasound is better than an MRI when it comes to diagnosing congenital anomalies, especially when you want to know the myometrial thickness and all. You need to get a good image like this to know how much of myometrium. So you know if you have resected till here also, you are not going to perforate the uterus. So a good 3D ultrasound is more important than a laparoscope. So if I have a good 3D ultrasound, I don't always concomitantly put a laparoscope for septal resection. If I'm putting it only because of fertility, if you want to know the tubal patency. But if somebody has already got a HSG done, demonstrated tubal patency, and that's demonstrating only a septate uterus, then not routinely combining with laparoscopy. If already, I find 3D ultrasound is more useful than a laparoscope. Laparoscopy, you are only going to see the surface. You don't know this distance on a laparoscope. This distance you'll know only in the ultrasound. So good 3D ultrasound or MRI is more important. Even if you do a combined hysterolaparoscope, I always say, we can see what's in the room and what's outside the room. What's in the wall, you can't see it on an endoscopy. So it's always good to have a good imaging before you start. So this is a very classical bicarbonate, and this is a very classical septate. What we are seeing is slight depression, but not classical like this. So that also, after studying literature nowadays, people are publishing partial bicarbonate and resection as the treatment. So what you need to do, again as I mentioned, this I've taken from somebody because I'm almost always using a scissor only for septal resection. Actually it doesn't bleed, you don't lose your vision. Originally it was thought when you use only a scissor, it can start bleeding, you lose your vision, so cautery is helpful. But almost, I think in the last 8-9 years have used only scissor, and the results have been good because we end up delivering them also. No? So in section under the cavity is very neat. So and many times we have done a secondary look also for some reason, cavity has been good only. So only thing, as you can see, it's a 30-degree telescope. So you will end up seeing more of the anterior wall. So your orientation every now and then, you'll have to make sure you're in the center of the septum. Otherwise your tendencies you will cut towards the anterior wall because it's a 30-degree and your scissor is in front of it. By default, you'll end up cutting more towards the anterior wall. So every now and then you'll have to come back, see where the ostia is, and remain in the center. Here if you're using a 12-degree, obviously it's easier, but since most of us have 30-degree only, so we'll have to keep coming back. And see, this is how it is going to be. This much avascular, you don't really get to see much bleeding. The other advantage is when you go towards the fundus and it starts bleeding, no, you know you're somewhere near the myometrium, you can stop the procedure also, especially in a partial. So keep cutting till you get the ostia in the same level. So started nowadays I realize most when I attend the conferences or when most of them are recommending scissor only for septal resection because it doesn't destroy the endometrium. So cautery destroys the endometrium, especially if you're doing for fertility and getting good results only. It's not that it's not technically difficult also. And honestly, probably why I started using scissor was feeling safe, you know, in a cautery comparatively. So I started trying with, because at that time, 1 or 2 conferences I attended, some people had tried scissor. I said, let me try. This is what I'm talking about some 10 years back. And then I found it was quite easy to do that. So now my fertility specialist does it herself. She doesn't even call me for septal resections. She's happy chopping it off. So she feels very safe with a scissor. She knows she can't do too much damage to the uterus with the scissor. So she doesn't even call me for septal resections and all. So you keep chopping it. At some point, no, you can see these kind of little gaps. At some point, it starts bleeding. That's when you know you kind of reach the myometrium part and you can stop. And it's always better little underdoing than causing a very thin. Okay, so this is and this is, yeah, this is the Bertuzzi. This is the Bertuzzi hysteroscope. So as far as I said, most surgeries can be done, and this is, I have whacked, I don't know where I got this video because obviously I don't do this, must have used somebody else's video. So this is the needle that comes with Bertuzzi. So otherwise people use Collins knife. Collins knife will have the same principle, you know, left to right you skip. The speed of a Collins knife with a cautery is much faster than a scissor obviously. You just keep going like this and will finish very fast. This is slightly slower, but the time you take to arrange the whole setup, no, you would have finished the septal resection with scissor.
Really have the control,
We have to with the thing.
bipolar.
This is bipolar. This is, I think, I'm not sure that's it's not my video, it's somebody's. See, other thing is this is another controversial whether all. This was a residue. Okay, this is not planing. Anyway, this is a residual septum. Sometimes we see subseptum like this also. So sometimes the fertility specialists would like that also to be removed especially if they've had a failed IVF and all. But this kind of is a little controversial whether it's really useful or not. But no harm in doing it if you find one. The other thing, endometritis can appear like small micro polyps when you really go close by, can resect it, but why we need to know is from the point of view of the failed IVF, that's when the role comes. So this is how an endometriosis. The other very satisfying surgery according to me after septal resection is removing the missing IUCDs, which is basically go under vision, use a grasper. What you have to remember is your graspers are very fine instruments. So when you try to hold the limbs of the IUCDs, the grasper ends up breaking it. So if you actually have a thread which has gone in, hold the thread and pull it out. Otherwise, very gently you will have to hold the limbs. By tendency, we tend to press it a little more, it ends up breaking the jaws. So just hold it very gently and pull it out. Try to obviously hold that's all, just hold it and come out, bring out the whole system out together and it comes out. Okay, this is incidental finding. In a patient with adenomyosis, you'll have what we call as deer skin, reddish spots will appear on the endometrium. Obviously, hysteroscopy is not the mode of investigation for adenomyosis, but incidentally, if you've gone in for abnormal uterine bleeding and you find these spots, you know you're most probably dealing with an adenomyosis. The other thing you can theoretically see probably once in your lifetime if you're lucky is the bony metaplasia. So basically we will see bony pieces in the uterine cavity. Either if they've had a mitral abortion, you know it's a retained blood, but you also see de novo metaplasia and it causes infertility. So you will have to mechanically, here again a grasper is used to pull out the bony pieces. Okay. You want to take a break? Is there a coffee break? We can get it, we'll take a break when the coffee comes. What time, yeah? When we were in training period, no, we used to wait for coffee. You're recording this anyway. We used to wait for coffee breaks and breakfast breaks and lunch breaks. Anyway, he's recording it, so I need to be careful. Anyway, the other borderline issues is, again, with time you learn is to differentiate hyperplasia with low risk, high risk, and pre-malignant. Though I'm going to tell you the theoretical part of it, practically it is like, keep doing it, send it for histopathology. With time you'll kind of figure out which is malignant, which is probably malignant and all. So basically if there is simple hyperplasia without atypia, they usually appear like a thickened endometrium. But what's different is they'll have little polypoidal appearance, unlike just a secretory endometrium. Secretory will be thick, but it won't have these kind of polypoidal. And sometimes you may notice a little increased vascularity, but not always. So this is a hyperplasia most probably without atypia. So when you see with atypia, quite often the whole endometrium may be hyperplastic. There will be localized area of extra polypoidal growth, and they're not uniformly thickened. There will be like, some areas will be thickened, some areas will be more thickened than the other. There will be little more vascularity, but it will be a little more organized compared to a malignancy. So I don't. Yeah. So if it is overall thickened endometrium, and it's uniformly appearing, I'll just curate it and come out. Okay. But if it's a localized, that particular area is looking more abnormal than the other, use a grasper and pull out a few tissues, and then after the procedure also do your curettage. But at least the representative areas, especially if it's sitting in the corner and your curette is not going to reach those representative areas, at least you can use a grasper. Sometimes it's a little more localized. I use a scissor and cut off the base like how you do for a polyp, and take out that piece, that chunk specifically, keep it aside. The rest of the endometrium anyway you're going to curate. But at least if you know which area is a little more localized abnormal, you can pull out biopsies from those areas. You get a biopsy forceps also with one of that grasp the tissue well, unlike a grasper. But again, everything comes with a cost, so most of the time we end up using the regular graspers only. So I thought I had, anyway, I had a video of a malignancy. I thought, let me just see if maybe the next slides, or was this the video? Yeah, this is the patient with proven malignant. I mean, later she turned out to be malignant only. So it's very classical, like irregular cauliflower-like growth. The entire cavity will be covered. In a hyperplasia, you won't, it's uniformly. Here you can see here and there, like mushroom-like growths, cauliflower growths, and it will have this kind of abnormal vascularity. This was a proper endometrial CA only. It's postmenopausal lady. So here, sometimes grasper comes. When you curate, sometimes it doesn't come out. A lot of tissue does, when it's very fibrous, I don't know. Sometimes this malignancy, they don't, when you curate, tissues don't come as much as you think it will come for this kind of thickness. When they're friable, they come out. When they're not friable, sometimes they don't come out. So you can use a scissor and cut, this chunk of it, the base of it, and pull out the tissue. So you have not missed anything. I think this particular case only, curate, nothing much came, but when we went in, it was all like multiple blows. Then finally, I think we had to use a scissor and cut a few pieces, and it was malignant. Okay, this was what this was something I've done 4 months back only, 4-5 months. She's pregnant again. So she was basically somebody who had a mid-trimester abortion. Before that, somebody had told her that there was a cervical, they saw a polyp when she was around 8-9 weeks and pulled out the polyp in the OPD procedure when she was pregnant. And then at 16 weeks, she leaked and lost that pregnancy, and she kept bleeding on and off. And then mesoprostol, everything was done again, but she came with this, she came later with scan showing thickness. So there is a query polyp and query retained product. Histopathology came as retained product on the polyp, the base of the polyp. So here, but otherwise routinely, the retained products, it's generally very flimsily adherent to the uterine cavity. It's easier than a polyp also to remove this. So when you take the scissor, it just nicely shaves off. Only thing, the vascularity, yeah, you'll start noticing a little bleeding like that, but it's settled on, it's not a big deal. When we curate, I think we do much more than this. So on a hysteroscope, it just looks a little more magnified. So here you're just localized removing the retained product. So especially when it's a smaller retained product, you know exactly you removed without any doubt. And also you're not unnecessarily damaging the rest of the uterine cavity by harsh curating, because you kind of removed everything. So almost always nowadays I'm just doing a hysteroscopy only. I'm not. So as you reach you lose the vision. So sometimes you'll have to come out and go. So the yellow part of it is the retained product. But there was little pinkish part, which they finally told it's a polyp with, and both tissues were chorionic tissue and also the polyp. So the advantage they found that over the just ultrasound curating, there's lesser adhesions and secondary infertility is reduced when you do a hysteroscopy. So given a choice, if there is a retained product and you finished a training, please do hysteroscope. If you have it in the hospital, don't do a blind curettage. Always use a give it some time. They'll stop bleeding ultimately. Do it as a hysteroscopy procedure. One, you have definitely removed. Second, we have an image. I always take a pic when I'm doing the procedure. So I take a pic and show it to them. So this is what was there, and we have removed completely. And I show one, and at the end also one picture. So that way they are also satisfied. So whenever you have a retained product, and if you want to do hysteroscopy, start with one of the simpler procedures you can do.
Long-standing retained products, AV malformation can happen.
Yeah, long standing. So you will need a good. No, but in a scan you can make out. Here you can't make out. So any procedure, it's good to do a transvaginal. I have this habit of doing a TVS myself before I take up the patient for any procedure. Yeah. AV malformation can be very nicely seen in the myometrium. No, in the myometrium you can see a proper, it's not a smooth myometrium. You can see the areas of vascularity. The only thing I find is sometimes the radiologist giving AV increased vascularity, query AV malformation, query gestational trophoblastic, but it's not difficult. If you do the scan yourself, you can make out a normal myometrium and the retained. There's a proper differentiation of the endometrium and the myometrium. Otherwise, you can see the invasion. In an AV malformation, you can actually see the invasion and echogenicity is there in the myometrium. Unlike a retained product, the echogenicity is only in the cavity, it won't be in the myometrium. AV malformation is seen in the myometrium itself. Of course, you need to, if you need to be really good sonologist to tell you it's AV or GTT, but beta HCG is there on our part, we can always pick it up. So this again happened a few months back when after a cesarean for twins, this is my first episode of AV malformation post cesarean. She came with profuse bleeding, and my radiologist, 1 month, secondary hemorrhage, bleeding, you don't think it's usually infection is what you think. I routinely got an ultrasound, she said AV malformation. I'm like, AV malformation, like post, well, I had never heard of it. So I put the scan myself. I could see a nice hyperechoic area in the myometrium, That's when I realized, yeah, what she's saying is correct. And others will think placental remnants, but they appear different. And then took her for embolization. You could see a nice blush in the myometrium. She's okay now. Baby is around 4-5 months old. So far, okay, no more episodes after that. So you can see nice hyperechoic area in the myometrium. Unlike this will be in the endometrial cavity. So you can make out very vascular. I'm not that good at scans, but good enough to see what's in the cavity and what's in the, at least you can discuss with them what's in the cavity and what's in the myometrium. Seriously, that's the first time I saw in my patient AV malformation coming up after 1 month. I'm still, don't know why that happened. She was IVF pregnancy, first IVF, then second embryo transfer with twins. Straightforward case. Why it had to happen? No idea. But
come across IVF pregnancies with lot of vascularity in the lower segment, like how the placenta previa, like that it will be.
Yeah, it will be in the myometrium. Yeah, so sometimes it's good to always either you have a good sonologist or go watch when they are doing the scan. That's the other thing I do. I tell them, you call me when you're doing the scan. So at least, and with time, when you keep seeing the images on the scan and then you actually do a laparo or a hysteroscopy, you are actually a better person to interpret those images also. We are constantly seeing on the scan and then seeing actually what is there on the laparoscope or the hysteroscope. After some time, your kind of mind knows what to read, kind of a thing. Okay. So see other surgery which is, so there are some surgeries which are totally gynecologist domain. One is this cannulation. So and it has especially corneal blocks. The results are amazing, especially when the HSG or even a chromotubation shows a block, but it's just a muscular spasm or something. The results which we have got in our infertility patient has been really good when it came to cannulation. But the only ones that don't respond, the really fibrotic ones, there where you're not able to cannulate, that is kind of, you have to go for IVF. But quite often when a HSG shows, one is HSG showing block, and then when you do a chromotubation, it opens up. So that is there. Other than that, whenever there is small muscular debris or something which is blocking even on chromotubation, it's very satisfying, the surgery. I will show this video after I finish the talk because I couldn't insert that particular video here. It kept having some corruption. See, these are till now what are the definitive proven treatment in operative hysteroscopy. Now comes the controversial ones, which we are not sure whether it really helps. One of them is a T-shaped uterus. So T-shaped uterus, we do a lateral metroplasty. Basically, this part is very thick, so you need to resect this. But not all T-shaped uterus need surgery. So you have to try your initial regular methods of fertility treatment. Only if it has failed, then you consider, even like an IVF embryo transfer has failed, then only you consider. And it's not definitely proven always to help in terms of success of treatment also. These are one of those debatable ones. So for lateral metroplasty, basically you're going to use Collins knife. Again, the challenge becomes how much to shave. So it's just intuitive feeling over here. So you know, you kind of when you do regular diagnostic hysteroscopies, you know your lateral wall is almost in line with your ostial opening, you know. But here it will be much deeper, and you start kind of shaving with the Collins knife till you reach little bit, you're able to see ostia in your field, and also to sometimes you can see the normal myometrial fibers and you stop. The problem is when you're using scissors, you can nicely make out this difference of pink myometrium and all. When you are using cautery, it burns tissue, so you're not always very sure whether you have reached the myometrium, are you perforating through the cavity, you're not very sure. So you will have to little bit go by your subjective appearance and where you see the kind of ostia in the same line. So this is one treatment which worked. This lady did conceive and had a baby after that and fine. But I have done 2 more lateral metroplasties where it has not worked. So this is, I don't know, by default it worked, but this patient had a successful pregnancy after the lateral metroplasty. So this is one of the no, actually this was my first lateral metroplasty, so I was also a little hesitant. So I shaved a bit, then came down a bit, because obviously near the ostia the space becomes narrow, right? So initially though I did the upper half of the cavity on both sides, then came down a bit and did a little bit in the lower cavity. I didn't do too much in the lower cavity. I stuck mostly to the, I would say around 70% of the cavity only I did it. Very low, I kind of, it gets narrow there, uterines come over there, so you don't know where you'll end up perforating. So I didn't do much in the lower half. So you can see I'm sticking to the upper half only, and this was my first one. So that's why I was a little hesitant when I was doing this case also. For some reason she became pregnant, and because my fertility specialist, whenever I have done an operative hysteroscopy or a laparoscopy and she becomes pregnant, she refers to me for delivery. So I get to see the results, even especially myomectomies and all. It's very nice to see your scar is very thick, myomectomy scar. You know you've done a good suturing. Endometriosis also, whether the recurrence of cyst, all that. So all my lab hist by default she sends it to me. So that's why I end up knowing the end results also. And when they don't conceive also, she'll come and tell me. So that's how it works. Okay, now, of course, the commonest indication probably in our practice is for heavy menstrual bleed. Many times in a heavy menstrual bleed, you kind of, if the scan does not show a pathology, you may not really find anything inside. But this is a good time to start doing history. Instead of, anyway you're taking the patient for a DNC, for endometrial biopsy, unless you're doing a PIPL, but if anyway you're taking for a DNC, put in a scope. What I do is if they come with active bleeding also, I start them on norethistron, stop the bleed, a week later take them for hysteroscopy. Because when you're actively bleeding, traditionally what we do, we take them up for therapeutic curettage. Instead of that, norethistron works really well. So start that. A week later when the bleeding has subsided, put a scope. So this is where you start. Somebody asked me now to start you only asked me. These are places where you start doing the hysteroscopes. You're doing a diagnostic hysteroscope, the whole endometrium is thickened, so you kind of figure out how the endometrium, and then do a regular curettage and come out. But you can start with abnormal uterine bleeding, especially when you know. But otherwise, by the book, the indication is obviously, hysteroscopy is the gold standard for heavy menstrual bleed. But a lot of them will tell you that even a PIPL endometrial biopsy is good enough, because 90% of the time it does pick up the pathology. So when I'm talking to a general gynec and not a hysteroscopy specific team, so the indication specifically will be intermenstrual spotting, because you're looking at polyp over there. And there is a discrepancy between your histopathology and the symptom that the patient is coming with, especially when there is a thick endometrium on ultrasound and people does not bring out any tissue. That we know most often happens with polyps. because polyps always, many of them will not give you as a polyp. A large polyp will have cystic areas, so they will always on a TVS postmenopausal, they'll give you a second endometrium, and you have done a pimple, you have not got anything. So that's another place where there's a role for hysteroscopy, and of course no response to medical management. Okay, this is the last segment, but I think it's a very most important segment when you're doing operative hysteroscopy. Now, diagnostic hysteroscopy, we know we are not going to take much time, in and out, saline is a media, so we're not going to hardly see any complication. But where we are going to be seeing more complication is the operative hysteroscopy, and in that particularly makes sense, TCRE has the highest complication, followed by adhesiolysis. Now, coming to the complications itself, this is how we'll go, different aspects. One of the anesthesia, the positioning, the media itself. The most important part in the whole thing is the media related complications. Now, coming to the position, straightforward, we all know that faulty position can lead to nerve injuries. So, by practice, even if for operative hysteroscopy or for laparoscopy, I position the patient and then go for wash-up. Even though my boys over a period of time has figured out, but I still prefer to make sure there are no, because I've sometimes very straightforward TLH and all, and then patient, the only problem will have some funny pain, she'll have almost 7-8 weeks, she'll eat your head that it's paining kind of a thing. So I made it a habit that I position the patient and then only wash up. By that time, the rest of the team can arrange things. Now, in the distension media, we know we are either going to be using carbon dioxide. I'll just touch through the carbon dioxide for theoretical aspect. What will be interested is only these two, the glycine and the normal saline. Now, when we use carbon dioxide, the embolism can happen only if there are open blood channel. Otherwise, it's not so easy to have an embolism in a hysteroscopy. But luckily, among all the gases, we know carbon dioxide has the highest solubility and hence the lowest embolism rate. That's how we end up using it in laparoscopy also. Now, if there is an embolization, whether it's laparoscopy or hysteroscopy, the principle is the same. So, either you will have a sudden drop in the oxygen saturation, or there will be hypertension and dyspnea and all those things. And classically, you are supposed to hear a mill-wheel murmur in the apex of in the cardia. And the way to do it is basically, it's not our domain, it's the anesthetist domain. Put the patient in left lateral and put a central venous catheter and remove the embolus from the right atrium. This is the principle of treatment for carbon dioxide embolism. This principle remains the same, and actually this principle is more for the laparoscope. That's where you'll have probably theoretically have more chance of embolization. And here though, we are not even going to be using carbon dioxide in our country for hysteroscopy. So what's important is, only thing, if somebody for some reason is using carbon dioxide, what they have to remember is use a hystromat. As you can see, the Hamau is the one who has invented everything. So the hystromat is also named after him. They use a hystromat and not the laparomat and use the carbon dioxide for distension. Bottom line is, we are not going to be using this. This equipment only, I'm sure, costs quite a bit. So we are not probably even thinking of investing it. Now, when it comes to fluid media, dextrant, I've gone through it, causes anaphylaxis, not being practically used. What we need to look into is the glycine and the normal saline. Now, glycine is what was initially used because we were using monopolar cautery for operative hysteroscopy, easily available because the urologist in your OT were using 1.5% glycine, and that's what's available in the OT. But we know it is a hypoosmolar fluid. Because it's hypoosmolar, when it gets into our blood system, it can cause what we call as TURP or a TCRE syndrome. The detail, I'll go through it later. Let's focus only on the normal saline. Straightforward, whenever there is overload because of the normal saline, we know maximum it causes pulmonary edema. And pulmonary edema can be easily tackled with diuretics. So basically, we need to keep an eye on that part of the thing. So even if you're using normal saline, though the margin of error is much more, you constantly need to figure out how much fluid deficit you are having all the time. Now,
How will you measure the output?
so what we do, no, we have the delivery bag, no, the PIH bag that we have, that I put under the patient. Inflow, though, you will know. The outflow you'll be collecting in the bag doesn't have, you'll have to empty and measure. Ideally, we're supposed to measure every 15 minutes, but with time, you'll know how much is in the bag is there, no. So at the end of it, we just empty and figure out in the can, regular can only. Calculate the deficit.
You in lithotomy position, you cover with
Under the,
means
no,
that
under
will
the,
absorb some-
no, that much margin you'll have to give, no. Because the whole plastic goes under the buttock. So one is, so the outlet is in the, if you have an outlet, put it into, either some people connect it to the suction. Okay, I don't do that. I put the outlet into the bag itself. Otherwise, you can connect to the suction. But what you're going to lose is from around the cervix, that fluid is going to be lost, that you can't calculate. So, but then if you're having a good system, obviously you don't want it to leak around the cervix, because believe me, you lose the distension. So, you need a tight gripping when you're doing operative hysteroscopy. So, 90% is going to come out through your outlet. So, either you connect the outlet to the bag or connect it to the suction
Goes to drapes is negligible.
negligible. And make sure you don't lose too much. If you lose in drapes, it's better only, it's not in the patient. It's better to lose in the drape than have it inside the body of the patient. So, that much error also will be taken care of. No, practically it is not going to be possible to measure those. It's not like how in PIH, if you have this much of gauze soaked, this much ml and all, no one's done that, because I think only we do these kind of jugaad now. Otherwise, everyone has a proper system to inflow system, outflow system. We don't have such things, so we all make it with this kind of. But even if I'm doing a operative hysteroscopy like a polyp or something, I put that bag. Otherwise, it becomes a big mess in the OT. So everything collects in that bag. Operative, you can connect to suction, but if you're doing a simple procedure, put the bag below. At the end of the procedure, you can measure, or if you think you're doing a large, taking little time, somewhere halfway through, you can abandon, tell them to measure. So you already know how much has gone in. So, just to run through the systems. So, whenever we are using normal saline or lingual lactate, it's an isoosmolar system, can be used only in diagnostic hysteroscopies, operative with bipolar, laser. These are the only 3 times you can use the saline. For monopolar system, you need glycine, which is a hypoosmolar. I'll be talking only about 1.5% glycine, because that's what we are going to be using most of the time. Now, what happens is, what are we worried about? Whenever there's a hypoosmolar system getting into our bloodstream, it causes hyponatremia, and that is where all the complication is happening because of the glycine. So, just to give an idea, when the sodium level is between 135 and 145, which is normal, when it drops down to 120 to 135, patient starts becoming restless. So, that is the reason why we need to do these operative procedures under regional anesthesia. And the patient will tell you, I'm feeling restless, because when your monitor starts showing arrhythmias, hypotension, it is at a value of 110 to 115. So, that's when your monitor will show. But 120 to 135, your monitor is not going to show anything. The pulse, BP, everything is going to be normal. Only the patient starts getting restless. At that time, you need to abandon the procedure or control, or you're almost finishing, you have to finish fast. When the value is between 115 to 120, there will be more restlessness and confusion. Patient becomes really restless. That time, you definitely have to abandon the surgery. Of course, supportive treatment, because its hypoosmolarity has happened, you will have to give saline, furosemide, and ventilatory support. When it reaches 110 to 115, they complain of headache and sleepiness. This is when your monitor is going to show dysrhythmia and hypertension, and it's probably a little scary situation by then. It's almost like ICU requirement, managing with 3% saline, and again, Lasix and intensive monitoring happens here. Less than 110, you lose the patient. So, this has happened in the past for simple operative procedure. That's why you need to have a monitor whenever you're doing operative, which definitely, you should have ECG electrodes and something that monitors your blood pressure. Pulse oximetry is required for operative, and regional anesthesia that is why preferred for operative hysteroscopy, especially if you're using glycine. Now, other than this hypoosmolarity complication, glycine itself as a molecule can cause transient blindness, but luckily it's only transient, recovers after 24 hours, but patient tells you blind is scary at that point, but then that's because it has a direct inhibitory effect on the neurotransmitters. The other thing it can cause is seizures, and glycine itself gets broken up into glycolic acid, which is nephrotoxic, and ammonia, which can cause encephalopathy. So, what is, I don't know whether my next slide tells you this, but what is important here is, apparently for neurotoxicity because of glycine, there is, I forgot what the mechanism is, it's more often in female than in male, because they have ways that's better in the managed in males than in females. So, the complication is seen more often in females than males. I think even uterus is a little rigid organ, so you need a lot of pressure to distend the uterus, unlike a bladder. So, the toxicity is more often seen when we do operative hysteroscopy, more when we are doing TCRE. That's why it's called a TCRE syndrome, because we keep shaving so much of the endometrium and opening the vascular channels. So, that's why it's more often seen in, the only other place we'll end up seeing probably is in a large myoma, submucous myoma, because spending a lot of time shaving them and exposing those vessels. So, these are the 2 places where you probably see glycine toxicity. So what's very, very important is you constantly keep an eye on the input. Output you'll know, but at least definitely keep an eye on the input. So don't keep on doing the procedure without keeping an eye, or a technician should keep telling you how much fluid has gone in. Every time he changes a bottle, he has to inform you. Ideally, every 10 to 15 minutes interval, you're supposed to know the deficit. We know practically it's not always feasible, but at least input though you can definitely know every now and then, because there is a limit for the input also. So now, what are the deficit we are looking at? Whenever you're using, earlier we would say 500 ml, but this is a newer guideline that has come up. So a deficit of 1000 is definitely a threshold for hypoosmolar solution like glycine. Preferably keep it like 500-600. This is the outer limit. The 1000 ml is the outer limit for glycine, but an isotonic solution like saline up to 2500 ml someone can tolerate. This I am talking about somebody who's young, like if you're doing for an infertility, who does not have any comorbidities. But if you are doing in an elderly with comorbidities, then it's 750 ml for glycine and 1500 for the saline. And what is important is, of course, you monitor the BP, ECG and oxygen saturation. Again, intrauterine pressure should not exceed more than 150 millimeters of mercury, because that's the intraarterial pressure. So try not to exceed that. And whatever, as of now, the recommendation still remains at the end of 60 minutes, you abandon the surgery. Whatever, wherever you are, you have to abandon the surgery at more than 60 minutes. Of course, the faster you do, the better for the patient. So 60 minutes will be the cutoff. So then other complications, cervical tears, that can happen with any DNC procedure. Perforation, I'll talk about perforation and electrosurgical. So perforation can be prevented by, this is the same thing, the vaginoscopy only. Basically, quite often the perforation happens when you have done it with a dilator and created a false track. But otherwise, under vision, if you go, unless the patient has Asherman syndrome, we should be able to negotiate under vision. Now, when it comes to perforation, so this is a classical appearance when we have dilated the cervix blindly and go through the false passage. Happens quite often. So here what happens, you'll start seeing these myometrial fibers and this web-like appearance. And in the beginning, you'll think it's Asherman's. So, but this is how a false passage will appear on the, that's why it's very important you go under vision. So in this case, when you come out, you can see the true cavity was there. So this is, this happens when we have dilated or put a sound before taking the hysteroscope. So get into the habit of going with a hysteroscope under vision. So basically, even if you have created a false passage or a partial perforation, it's not a big deal. And if you have done a perforation with your diagnostic scope also, you know, it's a 4 mm perforation is not a big deal. You just have to abandon the procedure. Obviously, you're not going to get distension if you have done a complete perforation. So then, if possible, if you know that you made a fundal perforation, you know there's nothing much can happen in a diagnostic procedure. You can also use a ultrasound and check. You know, you can actually see when you're perforated, there'll be fluid around the uterus, right? And when you do a scan, you can see the tract of that perforation. It shows as hyperechoic tract even on the scan. To some extent, you know where you have made the perforation. The only concern is if you are perforated into the lateral wall and injured the uterines or something and caused a broad ligament hematoma. So you can just observe the patient for 24 hours. If the vitals are stable, you can discharge them. Only if you have done the perforation with an operative instrument, then when it is active, especially if you're using a monopolar system, you know the monopolar gets conducted throughout the body, there is a risk of injuring distal organ beyond that. So you have to do a laparoscope to make sure that you have not injured any bowel or bladder where the perforation is, you have to check. That is why it is important that in the beginning also, when somebody was asking me in that myomectomy, you should always bring, when you're activating the cautery, always go from the fundus towards the os and never activate from below to upper. After some time, when you get used to it and a little bit as you want to go, you can do. But principle is always go from the fundus to the os. So always try to do that whenever you're doing any operative procedure. So this is a perforation with a septate uterus. Actually, the perforation was anyway. Incidentally, I think laparoscope was already in the place because we were anyway doing a laparoscope for her. And this perforation was actively bleeding, but actually the perforation was done by the dilator only, not even by the hysteroscope. So whenever there's an active bleed, try not to cautery because it's a through and through bleeding and you're actually destroying the myometrium. Just take a suture bite. So if given a choice, if there is a uterine perforation which is actively bleeding, avoid cautery and take a suture bite because that will give better healing. So this is just to run through the thermal injury. We know that monopolar gets conducted through the body. So whenever there is an injury with the monopolar, you always have to do a laparoscope. Also, we need to be careful that when we are doing a monopolar system, the insulation of your electrodes is perfect. Otherwise, you will end up wherever the speculum or valsellum, and if there is a breach of insulation, you will end up having local burns. Not seen till today anywhere, but this is the theoretical risk that is there. Okay, then the hemorrhage. Obviously, any surgery, especially a fibroid and all, when you're operating or TXRE, there can be sudden hemorrhage if some artery gives way. So we have to use spot cautery. This is actually the patient I was talking to you all about who had secondary PPH. So this is what it looked in. This is in the region of the scar. There was a little thickness like this. So I was trying to remove that and send it for biopsy. I was shaving that part of the placental growth, and there was a sudden bleeder pumping from as I was doing the procedure. But for this patient, since it was first time I was doing something like this, I kept the embolization OT also ready because I don't know what I was honestly dealing with. Because the MRI showed there was some growth in the region of the scar. So went with the histoscope. This was little irregular like this. So I sent it. This is what came as placental nodule. And then she settled on with, first of all, I didn't even know how much I had to shave also because it's a scar region, and how much I had to remove, I was not very sure. But I was delicately doing it, and there somewhere one vessel gave way. And then that bleeding started over there. I think I paused and then continued the.
In such cases, would it help if we do it under ultrasound guidance?
It can. That's what I said. Ultrasound guidance is useful when they are doing Asherman's, and these are cases. But then there was sudden pumper started. So, and then I lost the vision also. Then used ball. This is only to demonstrate ball cautery. But ultimately, she settled down only with embolization. This is temporary. These are all 2016-17 when I was beginning my journey. This, of course, this balloon can be done. So this is one way. So one thing as you're operating, when you see, is to do a spot cautery. This is the technique I was showing, but not for this case. Like when you're doing a myomectomy and when you see a sudden spurter, take a ball and just touch it. The bleeding stop. Actually, they stopped the bleeding, but I didn't know again she'll come back with hemorrhage or what, and this diagnosis was not very clear. So I abandoned the procedure and did the embolization. So far she's good because we didn't know. She's 2 times she came in shock. So second time this was first time, so I just managed her conservatively. I mean, hemoglobin fell down to 3 and all. So it was that kind of a shock she used to come in. So I know I was very hesitantly doing this procedure also. So for histopathology sake, I did this, but then finally she settled on with embolization. But this is the technique you can use. This is what I was trying to show over here. Otherwise, no, this is bipolar. This is bipolar. So in bipolar, you can see there are 2. In a monopolar, you will have only 1. Bipolar, the electricity has to get conducted from here to here. So that is how it works.
Ball will come in monopolar also.
Yeah. Ball will come monopolar, bipolar. Even that won't have this other loop. It will just have the ball over there. Then, yeah, as I was saying, whenever there is hemorrhage, one is to use a spot cautery. If you're just not able to figure out where it's bleeding, put a Foley's bulb and leave a tamponade and come out. Remove it after 24 hours. Of course, uterine packing has been mentioned. No, I don't think that much it can tolerate. No, 30 ml maximum, because you're not dealing with a pregnant uterus over here. It's a rigid uterus. 3 ml only the bulb will occlude the whole cavity. I don't think beyond 10 ml you can push in, you'll feel the resistance. You won't feel more than 10 ml in the cavity. Because 3 ml is actually what completely occludes the cavity, maybe a little more for pressure, that's all. Uterine packing theoretically described, we know in a non-pregnant uterus it's not easy to pack a uterus because embolization is always there, or you have to do ligation of the uterine artery with laparoscopy. Nowadays, so many of us have started doing the uterine artery at origin, so that becomes an option. But I find embolization is much more specific, especially when you have seen them do embolization, you can actually see the bleeder and block that active bleeder. So it's very much more simpler for the patient also, given the choice. Otherwise, for some reason, if you land up in some major hemorrhage, you have to do hysterectomy. I've done one hysterectomy in my life. I was like, Harrowing experience. She came with post section, I think Mr. abortion or some about DNC, post DNC, cyclical severe pain. And then I called her, when you get the pain, you come. She was having hematometra, basically cyclical hematometra, because the internal os was stenosed. I thought straightforward, just dilate the cervix, she'll sort out. So took her under anesthesia. Luckily, for some reason, I don't know why I took a consent for laparoscopy, but I had not taken a consent. The one patient I've done without consent. Went in, you cannot make out where the the os is. The whole vagina was like, the cervix was taken up later. It was just there. You can see one small hole in the apex of the vagina. Just couldn't negotiate. No sound, nothing to hold. Hysteroscope, wasted a lot of time doing hysteroscope, couldn't do anything. Then we put in a laparoscope. We thought we will make an incision on the fundus of the uterus, and we tried putting in laparoscopically some dilator kind of a thing into the internal os, because that was stenosed. Her whole lower segment was completely adherent. So we made an incision, put in the dilator, and it came into the bladder. So it was like we made a bladder. Basically, at the level of the whole cervix was taken up, and there was nothing like cervix. It was like the uterus, and the whole thing was adherent to the bladder. So somebody who has sutured the first cesarean has taken up everything and sutured. So there was nothing. Then I converted to laparotomy. I still did not find her internal os. On laparotomy, I divided the uterus, just couldn't find the internal os at all. I thought it was really strange. I don't know why I landed up in such a situation again. And there was nothing like this bladder, and then there is uterus. There is nothing like, no space in between, no cervix at all. Finally, I did a hysterectomy on her and came out. Luckily, patient thinks I saved her life. Today she's going to see me after 5 years. That's one case. After that case, I tell them very, very rarely, one in a lakh, but hysterectomy can also happen. But I just tell them, theoretically this happens. The first time in my life I've done a hysterectomy without a consent. For my luck, she had completed her family, and touch wood, she did not make a noise of it. But these are things you can get stuck in your life. So always good to take. I know I sound silly, but I've started doing that, telling all the patients hysterectomy. Whenever I think there is a little more challenging than I think, I just say, very rare, usually agala and all, let's say, but I still put in that word and keep. Of course, delayed is this is the last slide. We all know about infection treated, especially when you're doing a resectoscope, like TCRE kind of a procedure. There'll be secondary shedding after 10 days, there'll be excess vaginal discharge and secondary infection. Adhesions we know, so the only way to prevent adhesions is supposed to be even though any procedure we do like Asherman and all, antibiotic has to be given post-op, especially to prevent adhesion. Some people have tried keeping Foley's catheter to prevent adhesions. They have kept an intrauterine device after removing the copper. Even I do sometimes after a difficult Asherman, but no evidence. E+P is what you have to give whenever you have done extensive hysteroscopic surgery. But the only proven treatment in literature is to do a rehysteroscopy after 6 weeks and the flimsy adhesion to remove it at that point. That's the only proven treatment in literature. Other things do not have evidence. The only other thing which I feel you should tell all the patients is failure for treatment. For some reason you've gone in and you're not able to complete the procedure. That one possibility is there, like as a casual remark you have to mention in your counseling. So it's good to have a good pre-op checkup, pre-anesthesia checkup, make sure there is good amount of monitoring, and most important, you have to have a good backup in your OT given a choice. The anesthetist who's aware of what can happen in operative hysteroscopy is ready to handle immediately and all. Okay, so this is where the complication ends. I think my lecture ends over here.
Only for screening case?
Yeah, only when I've done that. No, not for myomectomy. The only time I did that was that I told you there were 4 myomas. They were opposing each other. So then the chance of adhesions are more. Otherwise, only for not for septal resection. All we have not put for septal resection and polyps and all, and there has been no adhesion when we have gone in, or when usually I do the section on them, because they'll be usually IVF and all. I have found the cavity very clean. Never had a problem.
Relook hysteroscopy, when you do it,
Given a choice after 6 weeks. After 6 weeks, but costing, is always a challenge for us. If the only thing, if I can show.
And do you use any adhesion barriers?
No, I've only kept, as I mentioned, the
Foley's.
Not even Foley's. I remove the copper of the copper wire. I unwind it, and I keep the copper wire. For what joy I do, I don't know, but it gives me a psychological satisfaction maybe. that it has kept the cavity apart and it has worked. So I don't know. I mean, it would have worked otherwise, I don't know. But then I keep it.
Remove the
Copper wire and just keep the T. Okay. So this is one cannulation, quite a few cannulation which has, this is Novi's catheter. So it has an outer sheath and a guide wire, then an inner sheath. So make the outer sheath go on to the ostia, then put the guide wire. So you cannulate the fallopian tube with the guide wire. Then comes the inner sheath. This is the inner sheath, the black ring you can see. Then pull out the guide wire. Through the inner sheath, you have to put the dye. So Novi's catheter, a lot of people use all sorts of ureteric catheter and all those style, but this is post cannulation dye coming out. So there was a small polyp, if you notice, at the entrance of this. These are the cases which respond well to the cannulation. So this patient also conceived next cycle itself. Like I have a lot of people after cannulation which are like straightforward cannulation conceive in the next 2 months itself. So I feel that little polyp was something which prevented, and otherwise all the other factors were normal in them. So this, I have now stuck to using only Novi's catheter. I don't break my head. The whole system is very good. So Cook makes it. Can ETU and use it for 2-3 cases if you have used it nicely. I find that easier than trying to do with ureteric guide wire and that guide wire and all. I find this is more practical. So this goes in with your side port of your hysteroscope. It's meant for hysteroscope, so it makes it easier. Otherwise, people have used ureteric guide wires, and you can cannulate, but you can't put an inner catheter and start flushing and all this. This is meant for the diameter of a fallopian. So given a choice, any HSG which has a corneal block, and I put a laparoscope. For cannulation, you need a laparoscope to be done, right? So before cannulation, anyway, you do a CPT again, chromoperturbation, because you know how many times there will be a false positive HSG. So only in them when there is, okay.
Before you put scope, laparoscope, there is no tubal damage, you have to confirm and then do that.
No. First you do a laparoscope. You are looking at HSG showing block, or sometimes my fertility specialist would have anyway taken it up for some laparoscope, even if it's an endometriotic cyst or something else she found, and she tells, we have done a laparoscope. Either it will be a HSG showing block, or incidentally we have taken up for laparoscope as a workup for infertility, and we have found that there is no dye coming out. So especially if she's planning an IUI or not. Some cases are straightforward for IVF, then I don't break my head about it. But if for other reasons, male factor, low AMH, some reason she has already decided on IVF on them, and they're just doing for whatever, like chocolate cyst removal or something which will reduce her success of IVF, I'll be taking her up. But if they have good AMH and no other factor has been found, we incidentally doing a histolap or a proven corneal block on HSG. When we are doing a histolap, first I put the laparoscope, push the dye. If the tube is patent, that's it. But if the tube is not patent, then you do the cannulation.
If the tubes are looking very bad,
Tubal perforation.
So the only time when your tube perforates is a very rigid os. And see here, you could see the opening of the ostium with the polyp. There are times when it's completely black and you don't even know where the ostial area is. Little bit guesswork only you'll be doing over there. And when you push the guide wire thinking that could be the area of the os, you will end up perforating, and you will nicely see it on laparoscope. But then you know how thin it is. So it's not a big deal. I mean, it won't do any harm to the patient. It's just a failure of procedure. So even when we are taking a corneal block, counsel them as 3 possibilities. 1, we put the dye, the tube was open, it was a false positive. 2nd, tube is blocked, we are able to cannulate. 3rd, tube is so badly damaged, we are not able to cannulate. So counsel them beforehand only, these are the 3 possibilities. Other thing we routinely do for all our chocolate cysts, or any time when I'm taking off for histolap, when I'm suspecting adhesion, we also take a consent, because we know after that IVF will be the option if the tube is very badly damaged with hydrosalpinx. We counsel the patient, even though we have not seen a hydrosalpinx, for clipping. 50% give consent, 50% don't give consent. But at least from our side, we've done the job of counseling them that if I find because sometimes in endometriosis, you find it's very badly damaged tube and all, and you know this is going to go for IVF. We counsel that if there is hydrosalpinx, I'll clip it if there is consent. Some of them do not give, but it's okay. But at least we've done the counseling bit.
tubal perforation, we just observe.
Yeah. It's very, because this is 1 mm guy. It's very thin, no, so it won't do any harm. Only a cornua is a little vascular, so you'll have to keep a pressure for some time. It will settle down. You can't cautery there also anyway, so it will damage. So, but I don't think it's a big problem. Tubal perforation is not a big problem. It can't damage too much. Anyway, you have to put a laparoscope beforehand, so you know nothing is adherent there. You can't do badly damage anything. Even if you perforate a bowel with this guide wire, I don't think anything happens. It's too thin for it to cause any damage.
And you do tuboplasties?
I do. I didn't. It becomes too much in this lecture, so I didn't show it. Tubal recanalization and tuboplasties also. But tuboplasty as in recanalization has a decent success. But tuboplasty in the sense the femoral end puckered and all, we've done it, but it's like, the tube is otherwise already damaged. So we do it, but I don't think we've had a very successful pregnancy. Invariably, they'll end up in IVF. We just do it because we can. Okay, we've done something. We saw the adhesion, we released it. But whenever I found that the femoral end is very badly adherent and all, we've released it, made all those things, but pregnancy rates have been not good. Not good. It's not been good. I think the rest of the tube also must be generally damaged only. No, it's not been very satisfying. Anything else you want to know?
Do you have any pictures of monopolar electrodes?
It's exactly same as bipolar. It looks the same. The way you operate is same. Everything is same. I think one of the myomas was monopolar only. The left myomectomy. It was monopolar. It's exactly the same. There won't be any difference from the surgery or the way it looks. Only the loop will have 2 limbs in bipolar and 1 limb in monopolar. What is there in AV will be monopolar only.
We have bipolar, we don't have
When did you change?
It is all, but we don't have a monopolar system at all. I don't know if it was before.
It was there till very recently. So, madam, but bipolar hysteroscope she bought. That's my little reason. I mean, okay, in the COVID days I missed 2 years of COVID.
I think it's one trial.
I've not come for surgery for a long time. So when we were there, it's exactly the same. Nothing different. Nothing different. It's just the loop will have only, it's less confusing because there's only a loop there. Here you have a loop and another other end to cut trace. And in fact, a bipolar loop also, some of these local made don't have two. Only Stores has that 2 limb. But whom do I buy from? Home Surgical. No. The cautery machine I buy from Alan Cautery. He is right now the good but cheapest for the bipolar. So he has a loop also. So his loop does not have 2. There's only 1 loop. It conducts from, I think, proximal to the distal end, the electricity. So his is, that's what I use because it's.
Laparoscopic bipolar cutting is good with Allen.
I don't use bipolar cutting. I know, that's because of people who operate there. But anyway, I won't comment about it. Well, I'm a bipolar with harmonic person. I live in luxury, so I don't like to mess up and change my style of working. I know they have actually. I forgot who uses it there. Manju still coming there? I don't know who comes. After experiment, lot of trial and error. The way the harmonic dissection comes out, no. So I don't want to change. So I don't want to change. I'm happy with left bipolar, right harmonic. That's my system of working. Each one has their own style of working.